I've only had one apology, and that's from Ellen Loudon. Unfortunately, she can't be here today. And I can confirm we're quorum for this meeting. I'm just going to take the opportunity to welcome Rachel and Craig. Thank you very much for making the time to come and present to us today, and we're looking forward to your presentation. And I also want to take the time to welcome Mike to your first formal public board meeting. It's great to have you on board, Mike. And also just to make a very quick announcement around Naomi, who's been appointed through due process for a further 3 years as the partner member representing primary care. Well done, Naomi. Thank you for that. I've not been notified of any declarations of interest. Are there any declarations of interest on the agendas today? No? Okay. So we're going to go straight over. Craig, Rachel.
Thank you. Hello everybody, and thank you for allowing us to attend your meeting and essentially an opportunity to show off. I'll introduce myself. I'm Craig Lesby. I'm a GP and I'm the Clinical Director of South Sefton PCN, and I have with me Rachel Stead, who is our Strategic PCN Manager. So we're here to talk about that we've won the PCN of the Year. It was an exciting event. I've never been to an event like this before. There was 600 people present, and there were 7 finalists in our category, and that's the team there that attended, went down to London, and the chap on the right who seems the most excited is in actual fact the compare, and is remarkably tall compared to the rest of us. We were very grateful to win, and we were recognised for our outstanding contribution to collaborative general practice, improving health outcomes, and partnership working to deliver integrated patient care. So I'll just say a little bit about who we are and why we won. Our vision of South Sefton PCN is probably very similar to the vision of most PCNs, and ours is to improve health and well-being for people living in South Sefton and enable a sustainable, resilient health and care system. South Sefton PCN was created by the merger of Bootle, Crosby and McGull PCN and Seaforth and Litherland PCN in April 2022. And in actual fact, that brought together the practices of South Sefton, who have a long track record of working together. We've got the same geography as the South Sefton CCG. And I think that's really helped having those strong relationships, not only between practices, but also with the PCN leadership and also with Sefton Place commissioners. You'll see that we are made up of 19 practices, and we deliver care to approximately 161,000 patients. So we're definitely big for a PCN. However, we keep that local responsiveness by having 4 neighbourhoods. And our neighbourhoods are McGull, Crosby and Thornton, Seaforth and Litherland and Bootle. Each neighbourhood aligns to their integrated care team and has their own deputy CD, clinical director, who in turn acts as their voice at the PCN Executive Committee team meetings. The neighbourhood model is really important for us. Neighbourhoods are empowered and encouraged to develop their own priorities for care and for services. But the truth of the matter is this, is that whilst there is a variation in affluence and deprivation across South Sefton, in fact we've never once found a service that's been developed in one neighbourhood that hasn't been applicable to all the neighbourhoods to a greater or lesser extent. We do try and use data where we can, and we use the Cypher tool in order to interrogate some of the data for South Sefton and to establish and deliver some new projects. For example, one of the neighbourhoods identified high impact users and worked with colleagues in Merseyside to deliver a proactive approach to care and to try and improve and support those people. Separately, this ties into one of the questions from the members of the public, is that another of our neighbourhoods identified, again with Merseyside, people who are housebound at high risk of admission over winter. And we work with Merseyside to go out and see them with their consent, provide proactive, holistic assessment, do some chronic disease management for where it was necessary, and to draw in any services that were needed in a way of creating winter readiness for them. So, sorry, bear with me. Okay. So this is a busy slide, and it's included really just for the sort of central orange bit, and it's to highlight our strategic objectives. And you'll see that our priorities are to integrate primary care, and to do that, bringing practices together, delivering the services required within the directed enhanced service requirements for the PCN DES, to expand the workforce, and that we've done that by maximising the use of the R's funding available. And we also have a PCN-wide unified learning environment, because we identified early that actually, in order to get the workforce that we needed, we need to invest in training and supervision and to help ourselves out of the workforce crisis. And strategic priority 3 is to work at scale, and you will hear later about some of the ways that we have done that. I'm conscious that different PCNs work in very different ways. Some PCNs have put workforce and funding within practices. We developed a different approach for a number of different reasons. So we develop services across the practices rather than within the practices. And you'll see in the presentation later about how we think that's improved care and engagement of practices. And in fact, one of our practices commented about working at scale, that they wanted to be a little bit less like North Korea. And what they meant by that is that the inner workings of a practice often seems fairly secretive, and actually what we want to do is work together. So, this slide demonstrates some of the complexity, but it's part of the reasons why we won. So, general practice and PCNs work in a complex system, as we all know. The NHS is extremely complicated and can seem fragmented, but it's clear that it's about partnership working. Relationships are so important, and we work really hard to develop those relationships. And we have got great relationships across Sefton. And part of that is based on the fact that we are large and we are a mature group of general practitioners who have worked together previously. And just an example of partnership working, our neighbourhood meetings, Merseyside are represented on the neighbourhood meetings both in mental health and in physical health. And we also have the commissioners attending our neighbourhood meetings. Commissioners attend our executive meeting, and we meet with Deborah every couple of months. So relationships are really key for our success. So we're really proud of our Adverse Childhood Experiences, or ACEs group. It's a really great service. I often describe it as the jewel in the crown of the PCN. And one of the things that we have been really keen to demonstrate is not just clinical leadership, but increase the visibility and credit to be given to non-clinical leadership within Rachel and Rachel's team. And in actual fact, our Adverse Childhood Experience group, it wasn't really medically led. Rachel has led on this, she developed this service, and essentially that's fine, because actually it's not really a medical model. So if we could play the video.
So I wasn't actually officially referred. It was actually my wife did the course, and just seeing the obvious proof of the pudding kind of thing. Every week she'd come home, our communication would get better. She'd tell me why it was the communication was getting better. We'd have less arguments, we'd have less clashes and stuff. And at the end of the day, I saw in front of me the results of the course, and I had to get on it. So I actually got one of the facilitators' numbers with their blessing, and got in touch and was just like, sign me up please. And yeah, it was exactly what I'd expected. So to give a very brief thing about me, I'm actually autistic, and I've been through childhood traumas. So although I knew the things intellectually, I'd never applied them to myself properly. The course itself, the way that it was described with like visual examples and very understandable like mediums, like having displays to show something, like the pyramid things, all that kind of stuff, it was really helpful for me to actually apply it to myself. And I know a few of the other guys said the same thing as well. Environment, when I first walked in, I knew I was right at home, because there was a load of smiling faces that understood that I was there for the same reasons as them, which honestly was one of the things that might have stopped me coming, was like me expecting a load of like really toxically masculine guys being all closed off and stuff. I walked in, it smelled like patchouli incense, and there were just a load of friendly faces greeting me every week. So the course as a whole, I honestly, I wouldn't even know where to begin. I'll be here all day. There's that many things that I've taken away from it. There's that many things that have improved that I've then built upon since then. I've only finished the course last week, and I'm already re-socialising myself after a really bad depressive rot. I'm reaching out to family members that I'd lost contact with years ago. I'm basically like rebuilding my life and making it better than it was before, because of the course and because of the different tools that I've been given because of the course. So my relationships with other people have improved in pretty much every sector that they could. I've gone from having an inner circle of about 3-4 people to communicating better with my partner, being able to be more patient with my daughter, be able to move on from trauma bonds, if you will, with my family, being able to actually process stuff that's happened and move on with them. Also being able to realise what kind of people are holding me back in life, and maybe not so much ghosting them, cutting them off, but just only giving them the amount of energy that I should be giving them. Also creating new bonds. I've made a very good friend in the group that I have joined a load of clubs with. They come round and we share our past with each other, and because we're very similar in so many regards, I do feel like that was like the first step in a lot of better socialising. So my health and well-being since finishing the programme have honestly started improving like pretty much straight away. Physical health, not only am I able to get past any previous pitfalls I might have had in regards to accessing healthcare, a lot of my anxieties have been dispelled that way, and I'm able to actually advocate for myself a little bit better. But on top of that, like all together, I'm just able to put myself back together in the morning a little bit better and start the day with like a good firm step. So since finishing the ACES programme, I've actually become a member of a charity called Sean's Place, which is almost like a youth centre for guys with mental health issues, essentially, is the best way I can explain it. There's always stuff to do. If there's nothing going on, you can always just go and sit in the tea rooms and have a gab with people. At the end of the day, just like with the ACES course, it's this unspoken understanding that everybody's there for the same reasons, and there's no judgment because of that. You can say anything within reason as long as it's not with bad intentions, and people will just understand that you're saying that because you are like them and you're not saying it for any underlying negative reasons.
Okay, thank you. So that was John, who went through our ACES programme, and we're very grateful for him for doing the video for us. But in fact, there were many people who can describe similar journeys. So another service that we have developed was our Sefton Access Service, and this was developed almost exactly 2 years ago with some NHS England funding to develop acute respiratory hubs over the winter period. And this was so successful both for patients who reported a great experience, got the treatment that they needed, and also for practices, that we have continued it ever since. It's expanded to take on more than just respiratory care. It's also for ear, nose and throat and urinary tract infections, and there's an intention to expand that further. And you can see there that we've treated just over 35,000 patients to date with great friends and family responses. And beyond that, the clinical lead, Chris, he has also done some training with regards to pharmacy first. A lot of the community pharmacists were not confident in looking at ears and that sort of thing, and has done some training events with those. And we have paramedics who rotate through this service. And what they have reported is that when they're back seeing patients in their own homes as part of for their work for NWAS, they feel much more confident in dealing with people with respiratory illness, having worked within the Sefton Access Service. Our Enhanced Health at Home service is a really great service. When the PCN DES first came out, there was a great deal of resource, understandably focused on people who are residents in care homes. But what we were conscious of is that there are also a number of people who are often elderly, frail, living independently, but just about managing. We were conscious that we wanted to try and support those people so that they could continue to live independently. And we developed a team of care coordinators and social prescribing link workers who contact people who have had an admission. They do a proactive assessment. They will assess what requirements are to continue for the people to continue to live independently, and then draw in other services wherever that's necessary, whether that be a review by the medicines management team, or whether they need some minor home adaptations in order to continue to live independently. And they've had a great effect in reducing the risk of readmissions. So learning disability health checks in Sefton, these were a bit of a postcode lottery prior to the PCN forming. Having recognised that, the PCN team created a learning disability health check team, and these have dedicated time. They contact the patients proactively, and they are happy to see people in their own home, in the surgery if they so wish, or at day centres. And by doing that, they've increased the numbers of people having the health checks considerably, and that's now a service right across all South Sefton practices. And there's just a fairly quick patient story there that just demonstrates the value of this service, and that's our Sarah, who is our nurse associate. Having made several attempts to contact the patient, she finally managed to contact and visited them at home, found them living in extremely poor conditions. They'd not had a meal for a proper meal for a number of days, and they were unwell. Sarah took it on herself to go out and buy a hot meal for the patient, and she liaised with the practice, highlighting safeguarding concerns to the practice and making urgent referrals and bringing in other agencies for intervention in order to keep the person well. Like many PCNs, we have a medicines hub. We've had a medicines hub in South Sefton for a long time. This is a group of clinical pharmacists who do a considerable amount of work for us. We have an innovative model that is employed in together with the Sefton Place ICB, and that helps engagement with the practices with regards to cost-effective prescribing and quick challenges. But on top of that, for patients and for general practice, the clinical pharmacists do our discharge reconciliations. Prior to this, that service took a considerable amount of time for general practitioners. That's now been taken away. On top of that, the clinical pharmacists do care plans for us. They deal with out of stocks, and I think anyone who works remotely within general practice or receives prescriptions know that there have been many drugs unavailable, and that takes a considerable amount of time. So the ability to have clinical pharmacists to do that for us saves us a great deal of time and to be honest, stress. On top of that, they do all the things that are required in their structured medication reviews, and they do clinics in practices, hypertension clinics, and started women's health clinics. So I will now hand over to Rachel, who will take us through a couple more slides, and then we're done.
Thanks. Yeah, we also wanted to describe, fundamentally we think that we won PCN of the Year because of our partnership work, and we've been able to, at PCN level, work really closely with our voluntary and community partners. And there's just a couple of examples of that. So we've previously been able to use some of our funding to create winter access community grants, so that we've had some of our smaller voluntary organisations in South Sefton able to deliver warm spaces and just some really small but important interventions to reduce things like loneliness. Again, we have, through our social prescribing team, we have a large team of social prescribers, and within that team we have some specialist work as well. So we have some social prescribers that are specifically working with enhanced health at home and our older population to address concerns around things like bereavement and loneliness. And we also have some social prescribers who are specifically working with patients who are newly diagnosed with cancer, or supporting them to access things like 2-week wait appointments where that might be challenging. Again, just working really proactively with specific patient groups, but embedded within our local communities. We also wanted to describe our future plans. I think we'd quite like to win again, so we need some good plans to keep us up there amongst the best of the PCNs. And I think Some of our success, as we've described, comes from having really strong and deep relationships with the GP member practices within South Sefton PCN. And inevitably, PCNs have started operating at a time that's been really extremely challenging for general practice, starting more or less at the same time as the emergence of COVID. So we've been through a consultation process that's lasted probably just over 12 months, speaking to our GP members about their vision for sustainable, resilient general practice. But again, speaking to our partners, we've engaged, spoken to Merseyside and to Health Watch about what patient priorities might be for primary care networks. And we've been really encouraged that the vision for collaboration is wide and deep. So there is more that we can do. But that comes in the context of knowing that patients want general practice to retain its identity. So we're not looking at, we're looking at how we retain the individual identity of each GP partnership, but in a way that offers consistency and clarity for patients, improved access. We've taken that consultation and that will become the strategic plan for the next PCN period. Again, there's some challenge around that because we don't know what the new contract might look like, but nevertheless, we still have ambition. So some of our vision we're describing through how we retain core general practice, so as I said, with that list-based practice autonomy. But we are starting to think much more about how we make sure that in a PCN of our size, we both meet the needs of that neighbourhood model, but also promote continuity. And we've done some learning from other PCNs and other models across the country, and are starting to think about how we might more effectively stream patients so that those for whom continuity is really essential are always seen by their own GP, and where the PCN has a role in enabling greater access for those patients within their own GP surgery by providing services to those that are generally well and for whom continuity is not so important in a PCN hub style model. The other reason for us to do that is that there are some really significant workforce and estate challenges in South Sefton PCN, particularly around nursing. That's quite high on our risk register. There are not enough nurses currently in South Sefton, and again, PCN is a good place to offer learning and development support to nurses that might be wanting a career within general practice nursing. So there's still more for us to do. Again, we are starting to think more about where can a PCN serve central services in terms of some of the administrative processes that happen within general practice, and how can we do that effectively together to allow greater efficiency. And I think as we come to the end of this 5-year period of the first contract for PCNs, we think that we've got our services to a place now where they are business as usual, and we are starting to develop a strong track record of effective delivery. I think what we know is that some of the reason for our success is that often staff in PCNs have time to spend with patients and can turn around some challenges relatively cost effectively. So for example, we've been working with a team to improve our uptake of child's immunisations, and for a relatively small amount we've been able to offer children an extra 800 vaccinations for their routine childhood immunisation programme, because we've got people that can go and speak to families in their own homes about why vaccination immunisation is important. It's the same with ACEs. A lot of what we do relies on relationship and people having time to talk to a professional about what their needs and expectations are. And we think that that track record means that we can show that we're ready for investment. There is an awful lot of ambition and capability within primary care networks. We know that there is more that we can do. And certainly thinking at neighbourhood level and within geographies, you know, the opportunities for us to engage further with patients around patient-centred care are obvious, and we're ready to do that. Thank you very much.
Well, thank you, Rachel, and great presentation of a fantastic achievement, and we're all really proud of what Sector and PCN has achieved on behalf of your patients and practices, and actually on behalf of Cheshire and Merseyside. Really, really well done. I've got one ask, really, rather than a question, but does anybody have any pressing questions? Go, Erica, Ruth, and then Warren.
Should I go first? Just to say, I'm really glad you got the opportunity to shine, because it's worth shining about. Apologies I was late. I actually am the chair of primary care. So my ask would be, because obviously we're short of time this morning, but if I can stay in communication with you, because there's some just great themes that we're looking at the moment: continuity, collaboration, impact on patient experiences, which is everything that you've hit today. So my ask really, because of timing, is that we contact you and we continue this dialogue, if that's okay. Thank you.
Ruth?
Congratulations. Absolutely. Congratulations. Absolutely brilliant to see the evolution of GP and local neighbourhood services, and particularly keen to see that the links with the social and voluntary sector and the inequality aspects of what you're doing. I had two sort of questions. One was, what's the impact on preventative services? You know, is this approach really having an impact? So I'm really pleased to hear your final bit about childhood vaccinations. But things like hypertension detection and management and you know, flu vaccination, is this approach really helping? Some of those was my question, but you've started to address that through the childhood vaccination example. The main thing I was going to ask you was, why have you done this, and what do we need to put in place to help other PCNs follow your lead? Maybe it's too big a question for today, and maybe that's something that you could follow up with Erica, but it's just wonderful to hear what you've achieved so far, so well done, and good luck for more work.
Thank you. I think it's Warren.
I think Ruth and Erica's just covered my question. It was, you know, clearly exceptional, fantastic stuff. How do we make this the norm across Cheshire and Merseyside? Thank you.
Now to you. Yeah, perhaps, and then Trish and Claire.
Oh, this is technology. I just want to say thank you so much for the presentation, and congratulations on behalf of Sefton Place and Team Sefton. I think it's a really great way of demonstrating the partnership working, and there is great opportunities to integrate more services around footprint, around adult social care particularly, and this new strand, health and wellbeing hub that we're in development with the council around. So well done from Sefton Place.
Thanks, then. Trish.
Thank you, Chair. Just wanted to add my congratulations to Craig and Rachel and to Deb as well, but also to thank you for your leadership in particular in this, and the experience as being as an organisation on the patch is one of a very constructive problem-solving approach, and one way that continue. I think what I'd like to say is there are some really important lessons here for us in neighbourhood development of the future. And again, going back to Arthur's point, I think we need to draw them out over as we start to think much more about neighbourhood unit delivery. Thank you.
Thanks, Trish. Claire.
Sorry. Thank you, and thank you in advance, because I know you're doing a similar presentation when the National Director comes to visit in a couple of weeks, so I think that's really great that she's coming up and has chosen, you know, she's coming up to see you, and we're organising a wider visit around primary care around you, so that's really good. And I think it's just really important today, because I'm hoping the planning guidance is published today, I think it is, And we know that primary care access and health neighbourhoods will be really key into that planning guidance. We'll have to do self-assessments, but I think it's really a great example, and we need to sort of work with you on those sort of self-assessments to see how others can learn, as other colleagues have said around the table. But yeah, massive thanks for everything you do. And I think it's really important that we acknowledge the wider system partners there, local authority, community health services, and voluntary sector and others. So thanks very much.
Thanks, Claire. Well, great, Rachel, your head's blue to really what fantastic presentation, really great feedback. So we're hearing, I think, really important, let's understand the progression and the lessons learned through the primary care committee. And Erica, if you can bring back to the board when you're ready. And that focus on outcomes we've heard from the group, that's what really matters, isn't it? The outcomes that you're helping your local population to be able to attain. Let's understand a few more of those metrics that you measure. You're really good to hear. But thank you very much. You're welcome to stay for the rest of the meeting, but we'll move. Thank you. Right, Greg.
Thank you, Chair. I'll be relatively brief, but there is one decision that the board needs to record, and that's acceptance of the recommendation to progress the next layer of delegation of specialised commissioning services from NHS England. You know, when ICB started, we took responsibility for all local commissioning budgets, all the budgets that CCGs used to hold, but the NHS England retained certain budgets. And that was about readiness of ICBs to receive them, and also the readiness of NHS England to divide them up and let them go. So we have the next stage presented here in some detail, so I'd like the board to approve this. I'm not going to go into detail, but it does seem that when we put this report together, it's longer than usual. And I suppose what I would observe is there's an awful lot going on. There's an awful lot going on with the new government. So there are some things for us to note very clearly. It is wonderful news that Secretary of State put out before Christmas what, from a government point of view, was called a capital grant. But that was how they sent the money. But once that money arrived with hospices, that's effectively a revenue income stream to support hospices who, like many other parts of society, have struggled with the cost of living crisis. So we're really, really pleased that government did that. We'd like the board to note the devolution white paper as published. I think that is something that we discuss in coming months, but our colleagues in Cheshire and Warrington know that they have our support for the work that they're progressing. And again, when established, both those devolution areas know that the NHS will continue to adapt and evolve to make sure that we are fully capable of working with what we imagine over time will become a new strategic footprint for the planning of all public services. I think there'll be in time lots of opportunities to discuss that, but please note the devolution white paper. NHS England is required to publish an annual assessment of ICB performance, but rather oddly they haven't got an agreed framework in place that allows perfect classification, and they are currently developing a new framework which in future years will look a lot more like a league table. But for now they have published a narrative-based assessment. We've replicated the key messages here for the board, and the full statement is available on our website. I was content that was a reasonable assessment of where we are on our journey. Again, that was something that we discussed very openly with NHS England as we went through that process. I'm also just making it very clear now that people should note that we are out to consultation on what the ICB's position will be on the commissioning of gluten-free products. And I published there the link to the consultation that is again on our website, and again also to bring people's attention to the fact that we are consulting on a number of policies across the ICB, largely to achieve standardisation where historically there would have been idiosyncrasies over 9 CCGs. We are one single statutory organisation. We need to make sure our policies and procedures reflect that. There are a number of other things in the report that I'm not going to go into today, but I'm really happy to take any questions or observations that either myself or the team will handle.
Thanks, Graham. Let's come to the specialised commissioning decision in a second. But take any questions on Graham's report? Pretty clear? Okay. Let's go to special. Oh, Ruth.
Thank you very much. I just wanted to say thank you for sharing the flu vaccination data. Obviously, we've had a substantial spike of flu circulating in the last month or so. And I know from the UK HSA weekly surveillance report there have been numerous hospital healthcare-based outbreaks of flu spreading. And also, although our staff absence data is only up till September, I would suspect that when we see the January figures and December figures, we'll see quite an impact. So vaccination has real consequences, the low level of uptake that we have has real consequences. So in the report, thank you that trusts were given additional funding, and what the data shows us is huge variation, overall very low staff uptake, but huge variation between trusts. So my question was, what assurance have we that the interventions were actually put in place?
And that has been the impact that social media has had on the public's appetite to engage in vaccination programmes. And if that affects the public at large, our staff are part of the public at large. So in terms of looking forward, we need to position ourselves in a very different place, because it's disappointing the level in the community at large, but also it is of concern because the first duty of frontline NHS staff is effectively to do no harm to their patients, and actually not engaging in vaccination programmes should be a problem to us. Now, I'm going to bring Ian in a second just to talk about the wider piece, but I am absolutely convinced that all of our organisations have the resources in place and the offer available to their staff. What we've lost somewhere along the way is that kind of moral argument around the encouragement for take-up, because, of course, it is a personal choice. So if I can bring Ian in, please.
Thank you. Just before you do come in, let's just follow that through a bit, because I think if we focus in on NHS staff alone and that really low level vaccination and the variation that we're seeing between organisations, it could be, I'm sure Graham is right in saying some factors are influencing thanks to social media, but it's a very, very unusual position to be in. The healthcare workers aren't normally anti-vaxxers. Healthcare workers are normally influenced by the evidence, and you get reasonably high take-up of vaccination. So something has happened. Trish, is there any insights you can give? But my ask really is for us to come back on this one with better understanding of what's actually happened in our organisations around vaccination, so we can put in place some really robust support into the future. But any headlines, Trish?
Yes, Chair, and Emily wants to come in as well. I think from a provider point of view, certainly what Graham has described is I absolutely concur with, in that it hasn't been about money or capacity to deliver. It has been about staff and public's choice in terms of not uptake on vaccine. And I think, Ruth is right, this has been a particularly very difficult spike of infection, and what I'm hoping is that actually out of that we will see change next year. I don't think the consequences of the low vaccine uptake has been really felt the year before in the same way that it has this year. And so, you know, people would say, staff would say, you get the vaccine installed, it doesn't make any difference to you. Actually, you get a low-level flu or something happens, and we're hearing that all the time. This year has been particularly difficult in terms of the effects of flu, and you know, hopefully we'll see some change in terms of the uptake. I know in terms of media and communications, every trust is doing everything they can, but there is something about public behaviour, both staff and public behaviour.
Thanks, Trish. So I just want to emphasise that we do need to learn lessons, and let's bring it back to this board. And if you would lead on that, Greg?
Yeah, so building on that, some of the things we're already putting in place around that is commencing behavioural insights. This is where we're going to be speaking with staff directly to try and understand, you know, what are those barriers, myths debunking, so they're going to, you know, is it fears around flu and COVID being together, for example, or other social media parts of that, and really getting down to some of that so we can, you know, shape what we do next year. There is something about us really trying to capture the moment now, because we heard it all in the media, all the impacts that Trish has described. That needs to be bottled when we start earlier. We're planning the summertime, but it needs to be starting early in September. There might be other certain things that we need to work with our trusts on. We're meeting with trust chairs next week, Raj, where we can raise some of those things with them as well, and how we can get it up on the agenda about the impacts of staffing as well as the communities that we serve. But it does mirror, sadly, a reduction in the wider population that we've seen in both flu and COVID vaccination. And I would say that's one of the main reasons why both screening and immunisations remains a priority of our forward plan moving forward.
Thanks, Ian. So give me a board when we can hear what those insights and understandings are. Give me a date.
I would suggest that we come back in just pre-summer so we can inform how we...
June?
Yeah.
Okay, June. Alison?
If I may, Chair, thank you. I think there's also information we don't have around the uptake rate in our primary care providers. Also, and I know it's extremely difficult to balance because of the recruitment and retention issues. I'm thinking about care homes and domiciliary care providers. You know, we've seen significant flu outbreaks in a number of care homes. I'm sure that's replicated across Cheshire and Merseyside, and at the minute we wouldn't know if there's a correlation with staff or resident. The resident bit is here. I suspect we have to start with what we can, which is the trust, but I think there's a wider view to come at some point as well. Thank you.
Thank you. Ian, could we incorporate that wider view? Thanks, Alison. I've got Warren and then Steve.
Madam Chair, my point's been covered, so thank you.
Steve?
Well, welcome Graham's comments on the evolution around adapting and evolving as the evolution journey continues. In Cheshire and Warrington, we were invited to submit an expression of interest to be part of the government's devolution priority programme. 12 places around in England have submitted expressions of interest, and we'll hear whether or not it will be accepted into the programme going forward. The reason I raise this is it's going to be quite significant for the whole of the ICB here, because mayors will be wanting to have more involvement in health, current and future mayors. So if there's a mayor, let's say from May 2026 in Cheshire and Warrington, that would apply, and it might have an impact on the footprint of the current ICB arrangement. But to look forward to working with you on it, Graham, because certainly there will be more interest in health from the mayor than has been shown so far.
Thanks, Steve. Okay, let's move on to specialised commissioning. There's a decision for us here. Any questions or comments on the report? Tony?
Just one comment, it may turn into a question, about the distribution of services in the charts of programme of care. The one query I've got is on mental health.
and the separation of CAMs across 3 levels, ICS, Northwest level and super regional, which is children, so look to be assured that there's good coordination of CAM services across those 3 areas. To go for children, I don't understand the separation of children and young people, so maybe a matter of detail we'll take an answer later, but I think there's a concern there that spread needs to be looked at. Brad?
Thanks, Tony. Yeah, we can do that. So we've got the joint committee, as you know, which looks at the regional level, but we'll do that, and I know we've already got work going on in terms of our lead provider collaborative and other work, but we've got a local group called the Strategic Specialist Commissioning Operational Group, which looks at what we internally commission into C&M and then how we work across with our colleagues across. So we'll provide that assurance through the joint committee, which Ruth chairs, and through the SCOG, which we can report through strategic tracker. So we'll do that. Thanks.
Thank you. The essence of this agreement is we become the decision makers. But there's a lot of specialist knowledge in how you manage these types of services, and we are retaining the services of the NHS England team, where they will effectively work for us on those things that we have become the decision maker, but they will still work for NHS England on the things for which NHS England are the decision maker. So the fact that it will be the same team of expertise working on the programme of work that falls across those, different boundaries, it's of course different when it comes into the nationally retained services, because the expertise sits nationally for that. But I'm confident that we will have the insight to be able to cognizant of one part's decision of impact on the other.
Thank you, Graham. So I'm moving to seek the board's decision on this request for approval of variation to the specialised commissioning delegation agreement as set out in the agenda, in the appendix. Anybody disagree? No? Okay, that's approved. Thank you, Graham. Chris, can we move to your paper, please?
Thank you, Chair. So the Director of Nursing Report provides an update on 3 areas this month, with the first being the progress today on patient safety strategic development. And the report highlights that part of the ICB's role as a strategic commissioner is to keep those who use the services in commission safe and protecting them from avoidable harm. You'll see within the report there's a quote from the World Health Organisation that estimates that 50% of harm in healthcare is avoidable. And the ICB has a unique ability to act as a system convener and allow safety to be managed, and there's an opportunity for system learning because we can bring partners and organisations together. You'll be aware of the National Patient Safety Incident Response Framework that's been implemented, and that provides a significant basis for the ICB role to provide oversight and for providers of providers' implementation and delivery of this framework. The report mentions about that safety must be viewed as everybody's responsibility, as a failure to keep people safe in one part of the system can have an impact across all aspects of care delivery. And it's not only a moral imperative, but given the estimated costs of avoidable harm, it's also a financial imperative. The report details the AQUA framework and it shows the areas that allow us to focus on those essential ingredients that, as an organisation, require for system safety. We are developing a system-level programme that includes the aspects of this AQUA framework, and they will be translated into a system safety plan linked to the commissioning priorities and our work on continuous quality improvement. Within the ICB, we've established a patient safety specialist community of practice, which provides a forum for ongoing support and a sharing of understanding and our opportunities for improvement. A number of our providers in Cheshire and Merseyside are demonstrating considerable expertise and experience in this area, and it's an opportunity to share the best practice where we can scale and spread that across the system. So the next steps are a further presentation is going to be delivered to the February Quality and Performance Committee on the development of a system safety plan, and oversight and monitoring of this will continue by this committee. And we would plan to bring a further update to the board at a later date. And the next item that I wanted to draw the board's attention to was the development of a co-production charter, which has been developed with our parent carer forum leads that we established within October 23. It's chaired by myself, co-chaired as well with the chairperson from the parent carer forum. And this meeting provides a platform for parents and carers from our 9 places across Cheshire and Merseyside to come together, and it ensures awareness of the current issues impacting on our children and people with special educational needs and disabilities and their families. And it's an opportunity to share their lived experience. I've attached the co-production charter within there, and you'll see that this is something we refer to at each of our meetings. So rather than a terms of reference or memorandum of understanding, we use the co-production charter at the start of our meetings to focus our attention on what it is we're going to achieve in that session. And the last part of the report is around the maternity services in East Cheshire Foundation Trust. So the report outlines the oversight of maternity and neonatal services, and it gives historic information there around the development of the local maternity and neonatal system, or otherwise known as the LMNS. Previously, East Cheshire has been overseen and supported by Greater Manchester's LMNS service, but to continue to provide assurance for the maternity and neonatal services, we are wanting to bring East Cheshire maternity and neonatal services into Cheshire and Merseyside's ICB, so that we can support and oversee the developments of the services within East Cheshire. So we plan to do that from the 1st of April. We've had discussions with Greater Manchester's ICB, and we've also met with the Trust themselves to have the discussions about that, how that will happen. So those are the areas that I wanted to highlight, Chair, today. I'm happy to take questions.
Thank you, Chris. Any questions, comments? Neil?
Thanks, Chris, for the report. I actually find it quite alarming that you say, based on the figures, that £1 billion of our £7 billion could be avoided, and there's avoidable harm. Is that realistic? And can we identify where we believe that avoidable harm is, and what would our action plan be to target specific key areas?
I suppose if I could give a specific example, I mean, you can actually attribute a cost to a harm. So if you were to take a fall, for example, Neil, the cost of the financial cost, not just the quality cost, but the financial cost for a fractured neck of femur can be given an estimated cost. I don't know at this moment in time what that might be, but if you were to multiply that with the number of falls that occur that result in a patient having a fractured neck of femur, that cost could be saved by the work that we could look at to prevent those falls happening within hospital, or looking at falls across the wider system. So you can attribute a cost to harm, avoidable harm, and there are a number of areas. I don't know if Rowan wants to come in on that and support.
So to build on that, in particular, the falls issue, if you read across to the sorts of things that are responsible for patients falling, often it links across to being on multiple medications, some of which interact and are associated with people dropping their blood pressure, which is therefore why it is not a surprise that patients can end up falling, with life-changing and at times life-shortening consequences. Now, we have certainly identified through our looking into the data that we are outlying. We've got a really high amount of prescribing both of opioids, of patients on multiple medications, 10 or more, and indeed at times 20 or more individual medications. And that is why there is an entire programme of medicines optimisation, looking at deprescribing, and where we do that well, and Sefton is certainly an example, not only does it contribute financially, but most importantly to me, as the medical director, we are starting to bring down the risk of harm associated with that. Have we gone far enough yet? No. Because we are still, when we benchmark to other parts of the country, have got very high levels of prescribing in this space. So does it continue to be an area of focus and indeed investment to reduce this harm? Yes, it does, and rightly so. And we continue to look to gather the data of impact on that. And then that, we can translate that across a whole host of areas. But that is one of the biggest areas that we're focusing on, and rightly so. Thanks.
Thank you. So there is a lot of evidence out there that answers Neil's question, and Chris, perhaps you could pull out some of that evidence, the international evidence, and then provide it to the board, the IHI papers, etc. I've got Ruth.
Thank you. I was going to say there's tons of evidence of what we should go at. I was more concerned with how are we going to prioritise where we put our efforts. If the safety plan is ready and it's going to the Quality and Performance Committee in February, it's essential that it informs our commissioning plans for next year. And so I just want to see that connected up so that we're clear that when we're making choices of priorities for commissioning, that we're informed by the impact of measures to improve safety.
Chris, before you, let me just link my question to that. We really need to be really clear and get the board approval for the outcomes you're looking to shift in that safety plan, those few other outcomes.
Okay, just to say, Ruth, that, excuse me, I don't know if I'm made clear, but the plan isn't developed yet. That's part of the Quality and Performance Committee in the development of the plan. So there's a presentation back to the February committee about how that will develop. So
that begs the question then is, when will the plan be ready and will it inform the next financial year's commissioning?
Can we meet with the February Quality and Performance Committee and we can bring that back to the next board?
I think what Ruth was highlighting, there's a timing mismatch. We actually need something before the start of the financial year, technically, to inform that commissioning plan. There's some alignments to be made.
Yeah. Excuse me, we're aiming to bring the commissioning intentions back to March. And obviously from May we'll be bringing sort of development plan and all the next sort of years documentation. So Chris, because obviously I attend Quality and Performance Committee, we can have a conversation outside of this meeting to make sure how we align that, because I think it's actually important. That was going to be one of my questions, because it looks really helpful. It's just how we dovetail and overlay to make sure that we're focusing on the right priorities that have got the greatest impact, but also we sort of, dovetail those outcomes that I know that are really important to the board and the organisation. So we'll have a conversation outside, if that's okay, and then we can report back. We can report back at the February meeting, but bring something to March.
So, I'll reinforce it. It's really important that we have our annual plan for next year. I think we're expecting it in April. Am I wrong in assuming?
Well, we don't have a meeting in April, so we'll see how we can manage it through the formal committee meetings. Okay. But definitely commissioning intentions as part of that sort of next year's planning cycle.
So the annual plan will be signed off in May.
Yes.
And the annual plan must include the priorities that we're going to focus in around safety to align with our commissioning intentions. Yeah. Okay. Okay. Yeah.
Just a very quick comment, if I may, within the safety plan and particularly within the culture. Could we reflect freedom to speak up? Obviously don't want to hold up anything, but we're working on the culture of freedom to speak up. Tenny's not in the room in a minute, she's going to present. But we just need to make sure that freedom to speak up is intertwined in everything that we're doing now. So, and I'll let you. Thank you.
Yeah. Okay. Christine, the charter, are you seeking the board's approval for that, or is that just for information?
It was just for information.
Okay, good. The sensible, alignment East Cheshire to the Cheshire and Merseyside on the next. I guess we can be assured that there'll be appropriate handover so that there's no gaps between the two entities. Okay, thank you. Are we happy to move on? Thank you. Mark, I think you're next.
Thank you, Jeff. The finance paper in your pack provides an update on the financial performance of the ICS system as at month 8, so that's November, within the financial year 24-25. Includes a number of pieces of information regarding performance against the financial plan and a number of other measures that we use to judge performance in terms of efficiency, productivity and workforce. I will take the paper as read, but I'll skim through some of the key numbers and key drivers for the performance report as described. As at the end of November, the ICS position has reported a deficit of 129.5 billion against a planned year-to-date deficit of just over 62 million, resulting in an adverse variance of 67 million, which is around 1.3% of our allocation. That's a combination of both performance challenges on both the ICB side, but equally including the NHS provider positions, and there's some further information set out in section 2.7 and chart 1 showing how that's performance has been achieved during the year so far, and equally the trajectories in each of the months, and relating back to some of the work that was done back in the summer about potential improvements in our financial performance and recovery trajectory as described in the paper. The ICS forecast financial position is also set out in the paper, and again in table 1 under section 2.6 you can see that we are currently forecasting at the end of November a forecast adverse variance of around £72 million against our full year budget, so that gives us a deficit of around £223 million. Again, that's across both the ICB and indeed the NHS provider position. Should say that whilst only a small improvement, there was an improvement between month 7 and month 8, so we like improvements in the current landscape. And again, further information in the report, but I'm going to return to that very shortly. Just in terms of the description of the year-to-date deficit position, again, this is consistent with previous months' reporting. On the ICB side, a combination of costs associated with continuing healthcare, mental health packages and prescribing costs. And as again, the board are aware, there is a series of actions and mitigations underway within the ICB to try and curtail and improve those areas of performance, and that's been managed through the recovery committee process, with a range of mitigations in place to try and improve that during the remainder of Q3 and indeed into Q4. With regard to the provider positions, again a combination of issues, costs associated with industrial action, pay award cost pressures, non-delivery of some of the efficiency savings that our trust set out at the start of the year, and a number of other individual factors which again are detailed within the report at section 3.9 across each of our individual organisations. Again, on the basis of taking the report as read, there is a lot more information in the pack, very conscious of that, but again, we monitor routinely lots of bits of information around agency, workforce trends, CIP delivery, and indeed cash, which remains a challenge across a number of our provider trusts, and particularly as we head towards the end of the financial year, needing to keep a careful eye on that and work as a system to mitigate those pressures. Just returning back to the forecast position, again to point you to section 3.33 and table 14, just around the different elements of the forecast position. So just to be clear that the ICB is currently forecasting a risk-adjusted position of £32 million against its planned surplus of 62. So that gives us 30 million surplus at the end of the year. There's further information then about the wider ICS combined position, which adds back to that 223 million comparing to the plan of 150. There is some further information in the report regarding risks and issues and mitigations. What I would say, obviously this feels like a little bit of time ago now in terms of the end of November. We have reported month 9 and it is sort of in line with the report here. It does give us a sort of level of credibility that, you know, that this forecast does remain true as at month 9. But again, we're looking to push further and improve the position where possible, working with partners within the system to do that. We'll continue to update obviously the Finance Committee and the Board during the remainder of the financial year, and obviously we're in close conversation with NHS England regarding the forecast outturn position and any available mitigations to close that gap back towards the planned position where possible. I will pause there, Chair, if that's okay. Happy to take any questions, but hopefully that updates the Board on performance at the end of November. Thank you.
Thanks, Mark. I think Graham, do you want to come in first?
Chair, I want people to view this in the context of this should be our last unusual year. An unusual year because of the way that the NHS nationally managed resources out of the back in the COVID pandemic, and how next year, when we discuss next year plans, we really will be in a situation where the money is the money and there'll be no money left centrally to kind of bail systems out. But when I say the last unusual year, there were pay disputes across every staff group which were settled at levels which would have been beyond any contingency that any ICB could have held. So it was right to hold that money back centrally. There were lots of other issues around other aspects of inflation associated with, you know, world events and prices. So we still present a report against what was our agreed plan, which should have been to have hit a 150 million deficit. But we frequently meet with NHS England, and NHS England have given us a number which would be our acceptable landing position for the year end. And when I say our acceptable landing position, a number that are given to every ICB, which allows the NHS still to balance its books nationally. So against the backdrop that Mark has presented a report that says we are currently at a 222 or 223 million deficit, which he is comparing to the 150 plan, what is the number, Mark, which I think I know, that NHS England have asked us to actually land this year?
Thanks, Graham. Yeah, the target is 200 million.
200 million. So with 2 months of the year left, we still have to find a £20 million improvement on where we are. Now, there are things that are in progress. There are further savings and efficiencies that are being delivered, particularly around the prescribing budget and in other areas. There are still cost improvement programmes that are being delivered by our trust that are kind of ramping up and will deliver slight improvements in position. But the other issue, of course, is we still have some balance sheet flexibility where we can discuss our accounting policies, being really, really clear that we won't compromise our professional integrity or our ability to pass the audit test. But certainly as we sit here today, we are determined to land this on 200. So whilst we're talking about a variance to the 150 plan at the start of the year, if we hit 200 in the eyes of NHS England, we will have achieved what they wanted us to achieve. So I don't want you to go away from here thinking we're still trying to get back to 150. That won't happen.
Thanks, Graham. Before I bring in Neil and Steve, let me just give a comment. I accept that, you know, this financial year has had significant differences from previous financial years in terms of the way the NHS has managed its money. But even if we strip those things out, we can see that our underlying position is not pretty, and we're not making the progress that we expected to make at the beginning of the year.
And where we sit today is, if we look forward, we are looking at a picture that's full of risk. Not just meeting our financial
obligations, but the consequence of that in terms of not being able to provide a certain level of service and the quality of service that we all wish to provide to the populations that we serve. So I feel really uncomfortable about today's report and today's position, and I think in weeks to come we will hear from the management team about how we can reduce some of those risks. Neil?
Yeah, I not want the final curtain. I've been through a few last unusual years in my NHS career, so this is just another one. I think the point you make, Ryan, is my concern, which I've always maintained, is I think the financial reporting is good. I think it's down where we are. We know where we're going. We know where we're heading with the risk. My concern is that achieving now a £200 million deficit as opposed to 150 million sounds much like success, but it's not. It's not because of the underlying position it's leading us into next year. And that's my concern about developing a medium-term service and financial strategy that we map and see where we're going to see how we're going to get out of this. Because I know from my experience, the one thing that financial deficits do, it drives inefficiency, it questions safety and quality because people have to take short-term decisions. We need some longer-term decisions, like the debate about have we got enough beds in hospitals. Well, clearly, unless we stop the pressure on A&E and get people out of hospitals, we don't have enough beds. So we've got to focus on that work around the community and the community sport where we get the best investment, but we can't do it on an annualised basis, and it will take some years. So we need a longer-term strategic plan. Together with the activity, we focus on the in-year position and we focus on the target for next year. But where do we want to get to? So we've got to think more strategically when we get through this. And I know next year it'll be another fixed year because late in the planning cycle. But hopefully the 10-year plan will give us some segmentation that we can start to work through. How do we address the underlying positions? How do we work this against the inequalities in the other plans? But what are the big things and the big ticket items that we need to do? So where we are, I'm concerned about what it means going forward, but we need to have that more strategic planning and alignment so that we can focus on what we're here to do and be realistic. It's no good saying the system will have to cope when we know it can't cope. We've got to be honest in terms of our assessments. And I think we can do that, and I think we've got the skills to do that. It's just creating the space next year. And I think a message for NHS England as well. The way the planning guidance comes out is unhelpful. It doesn't give us the opportunity, both with the financial resources. They also don't, to me, seem to be interested in the longer term or the medium term situation of organising. They've got to change their mindset so that we can work together on this. But yeah, I accept where we are. I'm concerned about going forward, and we've got to do that work to overcome the challenges.
Thanks, Dave. We've got Steve and then Andrew.
Well, just to echo what Neil just said, really, as you know, I've said here in this board before, the issue around the opaqueness of the financial planning, financial management, and how it leads to massive inefficiencies. And I don't understand why we don't start the year in balance, like other parts of the public sector. You make difficult decisions across the network, just make sure you start in balance rather than starting with a deficit. The deficit, in paragraph 2-3 of the report, it says that the deficit is going to be deemed repayable. But what deemed means actually, is it actually repayable in 26-27? If it is, on what terms is it being repaid? Otherwise, you've still got the deficit and you're paying it off at terms I don't understand. I'd much prefer us to move to a model which applies in most of the public sector, where you start your year in balance, not with a agreed deficit.
Thanks, Stephen. No, so we aren't going to rewrite the NHS and Treasury rules. We do balance once nationally. You've heard us say that before. But important question might be to answer about the repayables. Just to explain what that process is.
Thank you, Chair. I won't spend as much time as I probably need to, but in effect, yes, it is repayable. There is a set of rules that are in our operational guidance that I'm happy to bring back next time round because it will be a feature of our plan for next year. It is capped at a certain level, so that's around 0.5%, if you like, of overall allocation. So probably for us, for next year, it looks like around £30 million will need to be repaid, but that will then continue for a series of years, obviously given the value that we're at. So it will be a feature of our planning paper back to the board, and obviously part of our planning processes. The other issue that we have is around, obviously, our level of spend is higher than the allocation, so you'll hear us again in future meetings talk about distance from target and convergence, which again hampers us going forwards. But yeah, it's a feature of our financial rules that we'll need to explain to the board going forwards, but yeah, it is repayable.
Okay, so this headline figure there for next year, 30 million, it gives Andrew?
Thanks very much. Thanks, Mark, for the reports. I really want to just reinforce Neil's point about long-termism, or even sort of some medium-termism, which is it just doesn't seem to be available to us, Mark. Your reports are incredibly detailed, but they're exclusively about the current financial year, which has only a matter of weeks left to run, and yet we aren't really being cited in the board about financial implications for next year, let alone the medium-term financial plan that all institutions need to be able to make sensible judgments, particularly in respect of savings. The focus on exclusively on the single financial year does create across the entire system a short-termism in the search for efficiency gains, when we know that actually the real cost reductions are only possible when we're managing some of the fundamental changes and drivers of cost pressures, which are essentially long-term in nature. And I know I'm saying things that are very familiar to you and others around the table, but I do feel as a board we do need to get ahead of this and start to think more clearly about the medium-term financial framework within which all our institutions operate. At local level, we're seeking long-term relationships with NHS institutions to manage the consequences for residents, for patients, but also to plan for the longer term in terms of investments which will pay dividends over a generational period of time. It's very difficult to motivate those long-term partnerships when the instructions from the NHS at Cheshire and Merseyside regional and national level are so focused on the immediate financial year and never beyond that.
Thanks, Andrew. Look, rather than answering the question, I think what you're hearing, and we've heard over a number of months, is the need for us to have that medium-term financial plan in place in a level of detail that provides the board with assurance that we're actually attacking off underlying cost base as well as making best value for money decisions. I think what we're asking for is an understanding of when you think that's going to get to a maturity that enables the board to have that assurance.
Thanks, Jay. Yeah, I mean, just to agree violently with, again, Neil's comment, Andrew's point there, you know, that's absolutely our ambition. We need some key documents, hence the planning guidance reference that Graham made at the start of the day. That's been here, that will speak to the longer term, but again is the point that's being made. Looking for opportunities, looking for, you know, the benchmarked information that we have on, you know, what we can go at, where can we go at it. I think you've heard me probably say this before, I do have a level of optimism that within our system, which is a big system, spending lots of money every day, there are opportunities, we all know that. And we've probably got reactive costs in our baseline, but again, with some effort and some concerted sort of change through our commission plans and strategies, we can release back into that preventative space. So we get a number of examples which I won't go into, but, you know, there is something we can do around that. So in line with the planning timelines, I would imagine sort of the next 4 to 6 weeks, we will start to turn the handle on everything that we've got and turn that into a set of plans. That's going to take a little bit longer, obviously, for a longer term, but certainly by, you know, early March, mid-March, in line with planning deadlines, that's where we'll start to get to in terms of our initial assessment of the next few financial years and our plans that sit around that.
Okay, so if I could perhaps summarise, I think what the board's asking is, I think we need to see a 3-year financial plan. I'll call that the medium term. Mark, you guide us about when you think you're going to produce that. So the first iteration of the next financial year, we'll see the granular level of detail in March. I think I'm understanding, but soon after that, we need to understand that what the 3-year outlook is, and next year is the first year of that 3-year outlook. And I don't know if other people saw it. I thought it was interesting to see the national reference cost data that came out, and had some headlines just a couple of weeks ago. We talked about it well. And our ICB, where 100 is average, we're at 103, which shows that we've got some flexibility at that over a global level, but there's marked variation within our organisations within the ICB. So seeking to understand how some of those benchmarks will help us focus is going to be an important part, I think, of giving the board assurance about planning. Neil?
Yeah, can I just add to that, because it's not a financial problem, it's the service overheating where we're not managing it effectively. So to support Mark, the bulk of our deficits as this is at the moment are in provider organisations. Could I suggest that maybe through your chair networks and the chief exec networks, you put this message out to trusts, because I know trusts aren't looking medium term either. We need to help them with some planning framework, but unless the trusts get on board and aligned with the work Mark's going to do, we'll be making assumptions for them. So maybe a message through that network would be good.
I mean, very certainly we had that repeated message to chairs at least for the last 12 months. And some of our trusts do have 3-year financial plans. It's not all of them. Some of them do have 3-year financial plans. I can't attest to the quality of them. But that's what we're pushing for. The system is reverting back to its normal pre-COVID way of working. I think you can see some sensible guidance coming out from our national colleagues. So, yes, absolutely. Okay. I think there were no recommendations in here, but I'm not. This is here for discussion and no too long. Are we happy to move on? I'm conscious of time because I think we're going to lose Debs soon, aren't we, Debs? Yeah. So if I could just move around the agenda. But before I do, I'm just going to ask for some headlines from Erica on the Finance Committee report. She's waiting to send me some around.
I'll be super quick because Graham did a fantastic job. That was my first point about the 200 billion. And you used the word acceptance. I think we were thinking, what would the word be? We were coming around with tolerance to be 200 million. But I think we've covered off the current control total enough in our conversations. So I'll be really quick, just to advise, and it's in the paper, that an investment that we are making, it's not new money, but an investment that we are making is to ring fence longer term funding for our digital aspirations. So I think it's some really good news. So this is circa £8 million. It's around population health, so it's our data into action that we talk about. It's our shared care records, and as the chair of primary care, I know how much that will mean to all the 4 contractor groups around that. And it's research and innovation, so I think it's a real positive. And I'll leave it at that. Thank you.
Thanks, Erica. Were there any other questions for Erica? Happy to accept that report with that update about that decision. So, if I could ask Anthony just to pause, if we could bring in Tony and Debs to do the place report. Debs goes.
Thank you, Chair. Obviously, I'm conscious of time, so I'll be as brief as I can. But just in terms of, we've got my colleagues here, Deb and Alison, so I'm sure they will want to chip in as well. But you've got a detailed paper before you, really, which tries to provide some insight into all of the range of different activities across each place and how the place teams are working through their local partnerships to improve the health and well-being of their local populations. As I said, there are probably too many topics in the paper to cover in the time available and to give them justice. But I just want to probably draw out a couple of specific examples which demonstrate that real place partnership that exists at place and those collaborative approaches which really do underpin all that's done at place. So I'll try to bring that out in a couple of examples that I've got, and I'm sure Deb and Alison will also want to come in. So just in terms of the place partnership development and partnership boards, those take place on a regular basis. And there are a whole range of topics that are covered in those and discussed in quite some detail. For example, but also in terms of our support for our local authority colleagues in terms of the CQC inspections that have taken place or are yet still to take place in a couple of places, how we work with our adult social care colleagues on that, but also those things around SEND and ILACS inspections, in addition to all the health things and other partnership and community stuff that we do have conversations about. In terms of health inequalities, there is a really wide range of activity in those spaces. So you see a couple of references in there, for example, about the Poverty Truth Commissions, which have been established in Warrington and Halton. And those are really about how we speak to co-production and co-creation with our local communities and our partners and our third sectors, just in terms of trying to find some solutions to that, how we agree to go forward, what's the impact on the individual, what's the impact for our organisations, what do we need to do, and then how do we influence and shape some policy around that. I think it's important in this space as well, not just to talk about physical health, but also mental health. So a couple of our colleagues have given some examples in terms of health inequalities around what they're doing in relation to mental health and how they've used some of the health inequalities funds in that space to support mental health and crisis interventions for children and young families. But also if we look at Knowsley and Wirral as well, they've reported on good progress in relation to severe mental illness annual physical health checks, and they've made some really good improvements in terms of their percentage uptake of that, and I know other places have done similar. Obviously that's not recorded in there. Just in terms of patient discharge and flow, clearly that's never far from our minds in places we deliver on that on a daily basis. But I suppose we've got a comprehensive UEC programme wrapped around that, and we've heard about that previously here at the board. But what I would probably want to emphasise is the amount of partnership that goes on at place to try and make sure that is as smooth as possible, and in particular with our local authority colleagues. Our senior leaders are standing with us in that space in all of our places, attending meetings with us with chief executives, so I really do want to sort of pay compliment to that, pay tribute to that, because without them and our other multi-agency partners, we'd be in a far worse position. I think also I want to emphasise that it's not just about physical health, so we do talk about mental health flow, discharges, some of the challenges in those spaces, and clearly those aren't easy topics, but again we work with our provider colleagues and with the rest of the system, and of course we know that Simon Banks is our SRO around mental health programmes, is leading some work around rapid improvement, just trying to make sure that we can flow patients as quickly as possible. We've had quite a comprehensive view from Craig earlier around PCN development. Again, lots of work in that space. That will be a cornerstone of integrated neighbourhood working. Lots of examples of multi-agency working there. St Helens has done some great work with schools around absenteeism, etc., and complex families, for example. And we also know that we are responding to the results of the patient satisfaction surveys and what we're doing to turn that around in terms of accessing the whole PCARF programme. In terms of trying to move that on. I suppose lastly, by way of example, for other colleagues might want to come in, we just talk about children and young people. That topic gets a lot of attention in our place partnership boards, rightly so as well. You'll see lots of references in the paper around some of the neurodiversity challenge, and that agenda takes a lot of attention locally. But of course, we know that we've got a recovery programme in that space, but also the SEND and ILACS improvements that need to be made right across the patch, and the amount of attention that they're getting with our local authority partners and our school partners in education in that space as well. Probably one thing I probably just want to highlight, and Alison may want to come in with this, is the work that Knowsley's doing around Section 75 and putting children in that space. I know other authorities are doing that. But that's something that we need to look to do more of as we move forward. That's probably all I want to do by way of example, given the time we got, because I do know that Alison and Deb want to also come in as well. Deb, do you want to? I hand it to you because I know you've got to go.
Thank you, Tony. I just wanted to just draw the board's attention to the psychological support and recovery through to the victims' families and children as part of the Southport incident. Just to say that there was a short paragraph in the report that outlines the outstanding support that we have for partners in terms of the psychological recovery offer for those affected. And I think just to apologise, a substantive item was meant to come to board, but we've had to delay that for reasons, for internal reasons. So that substantive item will come to a future board. Just to say that in terms of outlining the recovery priorities in relation to Southport major incidents, we wanted to create an appropriate, accessible, effective family-led support for children and their families. Enhance, coordinate and ensure easy access to the full and graduated offer of practical psychological support. Make sure that we're building resilience in our communities and community leadership to deal with long-term impact and address hate crime and extremist behaviour, and our council's leading on that piece of work with our partners. Mitigate the short-term impacts and ensure long-term success of regeneration projects and the wider Southport economy and the impact of the incidents, and also create lasting memorial and legacy which acknowledges not just the loss of the children, but a memorial which celebrates their unique contribution they made in their lives. I just wanted to point out how we've been working in partnership. We've been engaging and listening to people directly affected. We've been responding quickly, creating a clear strategic framework for recovery, and ensuring we're open to challenge and learn from other places that have been through major incidents management. In terms of our current position, I just want to draw the board's attention to a council cabinet paper that was agendaed at cabinet on the 9th of January, and that will be details that will be circulated with the minutes for the board. And a local child safeguarding practice review will be starting in February, led by Lancashire County Council. Just in terms of assurance to the board from Sefton Place and Sefton Council, we continue to support the public that have been directly or indirectly affected by the events on the 29th and 30th of July. We continue to support staff that have been affected across the council and partner organisations, and we continue to be vigilant and report intelligence into police colleagues of any issues relating to community tension. We have an integrated comms plan that we and our comms leads work collaboratively together, ensuring that information is disseminated to public. I'd like to finally thank NHS colleagues in Merseyside, primary care and Alderhay for their continued support, and for the board to note the strength of our place partnership in responding to this tragic event, and our thoughts remain with families, children and victims affected. Thank you, Chair.
Thanks, Debs. Alison, was there anything you wanted to add?
No, thank you, Chair. It's very difficult, isn't it, to land this report because there is so much we can talk about from a strategic level right down to those kind of details. But I'm hoping it gives some assurance that as we move to a more sort of strategic commissioning focus that we're covering most of those things. So you can see the partnership working, you can see that very detailed work when we need to respond locally. I think there's good examples in there about how we're arranging and improving provision of services, but also, as importantly, we don't often talk about it, is that assurance of quality and safety at a very local place level. And I thought there were some really good examples in the report connected to urgent and emergency care and the work we're doing with care homes, which are about that prevention of admission work, if we could really work with our local authority colleagues as NHS to improve the quality of care in care homes. So I wouldn't want to add much more than that at this stage, Chair, so thank you.
Thanks, Alison. Board, any questions or comments? I'll make an overall comment on the report itself, and I think we've seen over the last 2 or 3 reports coming from our place directors significant improvement in the intelligence and the highlighting of the great work that's going on in each places. And it's good to see that consistency between 9 places as evidenced by the summary risk profiles that you put in. It would still be really good if we could understand better some of the metrics and the variation in the performance around the metrics between our places in terms of the outcomes, both at population level and some of the process indices that we know are going to be that are important on and that we know you're working on. But overall, I think this is a really informative report and hugely important to us as a board to help us understand what's actually happening out there on the coal face. So thank you very much for that. So if we're happy to move on, I'm going to go back to the performance report. Anthony.
Okay, thank you, Chairman. So board members will note there's a number of new additions in the integrated performance report. This paper clearly annotated, and that's following endorsement by the Quality and Performance Committee as part of a rolling development that we're running through to improve visibility of all sectors, and following some particular board feedback. So you will see things in there around mental health, community, and some health inequalities indicators coming into the reports. I think that the next step really is to get into improving some of the primary care visibility. We have got stuff in there around dental and GPs, but we're clearly wanting to get a reliable and robust data source for other parts of that sector. I wasn't necessarily, with your permission, Chairman, going to dwell on any of those areas, or indeed planned care, which is part of a paper further on in the agenda. I think it's only right at this time of the year to us to concentrate my narrative on urgent care, but also open up to any questions later on. And I'd particularly like to invite Rowan in with potentially Chris later on to talk about some of that clinical risk management and the steps that we're taking at the moment. So I know we had a wider discussion earlier on prior to the board meeting, but just to recap on some elements of that. In the run-up to Christmas, as we reported last time to the board, we were undertaking a number of events to try and decompress not just the hospital sector, but other parts of the sector as well in the run-up to Christmas. And what I would say is that, you know, as we went into that immediate festive period, we had achieved, certainly in our general and acute beds, an occupancy level of 92%. We did have the beds open, indeed we had more beds open than we had planned, and our non-criteria to reside rate was not only the lowest this year, but certainly, you know, an improvement on the same period last year. But as we're all aware, over that Christmas New Year period, that gain was very quickly eroded, and in certain parts of our system we started to see some real pressures emerging just prior to New Year. It wasn't necessarily down to high numbers of patients in terms of demand, it was down to acuity. Some of the points that Ruth pointed out earlier, we saw the peak just after the New Year in terms of some of the seasonal flu and other aspects, which was publicised as a quademic. And of course we did see that slowdown in discharges, which is perennially a challenge between the Christmas and New Year period. So during that first week, the week of the 6th of January, we did see 3 critical incidents declared across the patch. That was around Liverpool, St Helens and Wirral. And as a result, and in line with normal emergency procedures, systems converged and co-located and implemented measures at pace to try and address those particular challenges. Some of those steps did involve high numbers of patients being cared for in temporary escalation spaces, or sometimes referred to as corridors. We saw long waits in ED, we saw boarding on wards, and we saw patients discharged to social care settings for a short period before transfer to the most suitable setting. What I'd also say is that in each of those latter cases, those discharge destinations were a higher level of acuity, not a lower level. But we also saw quite a notable change in public behaviour during that period as well. I mean, it was a period when we experienced some really difficult winter conditions, and we saw a natural drop down in walking attendances. But we did see that almost immediately after the declaration of critical incidents within those certain patches and the well publicised status of that, we saw a dramatic drop in low acuity attendances at those A&E departments during that period. And we thought and were braced for almost a bounce back some days later, but that hasn't actually emerged as far as we can see. So an interesting one to follow through on as part of the debrief process that we will undertake. By the Friday, all 3 systems had met the criteria to de-escalate from that status, but the decision was taken uniformly that we would keep in place that incident status throughout the weekend to really test out the resilience of it. By the Monday, the 13th, those positions have been maintained, and therefore the formal decision was taken to step down. And one of the triggers in that, which was always the centric objective of the incident, in terms of trying to maintain ambulance turnaround and allow ambulances to respond to the most critically patients in the community. That category 2 response time was down to 35 minutes, which is actually a position we've only seen in this patch over the past year during the summer. So a real combination of system partners playing in that, including the public. But I would draw attention particularly to the support that we received from NWAS themselves during that period. They consistently put out more double crewed ambulances on the road than was commissioned or expected and planned for during that period, and they worked really well to allocate their resources around not only the Cheshire and Mersey patch but the North West patch, and dependent on where those pockets of pressure were appearing. So a real collegiate approach. We have, by all accounts, gone past the peak of that winter. We have been in a more stable position in terms of, bordering on critical incidences and normal operating escalation levels, but it's still a challenging period across all sectors, not just the acute that I've concentrated on quite acutely, but Trish will be able to say exactly the same position in terms of mental health provision, primary care challenge, social care challenge, but everyone keeping a real focus on that response. But increasingly what we've done over the past week or so is signal that we need to move past that initial almost emergency response to the situation. We need to transition back our approach to one of the programme for improvement that we've got, and that signal has been given to everyone. Part of that, and I think part of the national push, to see that almost transition back to business as usual approach and improvement approach has been signalled to ourselves. There is going to be a high degree of expectation for delivery of a more improved position during March. Our teams are excited on that, are expecting that. So I would think that the ICB and all its partners will be facing some real challenge during the month of March to try and see performance, particularly around the 4-hour A&E standard of 78% being delivered, and a real focus on that Category 2 ambulance response. We are geared up for that. We've always held through the urgent care improvement programme that our barometer goes beyond that A&E 4-hour standard. It is one of eradication of corridor care. And we mean that in the sense of not only the corridor care in the acute sector, but the corridor care which doesn't have much visibility for mental health colleagues, in the sense that these are community responses as well. So we're really gearing up to that. We'll ensure that the board members receive regular updates on progress, as we have been doing through weekly bulletins, voting on execs and to wider system partners, and we'll maintain that. So if it's okay, Chair, with your permission, I'll pause there and invite Rowan in to talk about how we were trying to manage during that response stage a real focus on the clinical risk in all of our systems. Thanks, Anthony.
Thank you. And I think this speaks to questions from our public this morning about how we look to keep things safe. It recognises the pressures where we run up to 20% non-criteria to reside beds, and how we're not going to immediately be able to fix that social care problem. So what is it, and to Graham's comment, what's the next thing that we can do within the system that we have control over? So indeed, individual support stood up across each of the critical incidents that were declared, exceptional ways of working, taking down and deferring some elective care in order to move doctors and nurses to the right parts of the hospital. But one of the repeated things that comes back is an ongoing narrative that says the most vulnerable patient is that who is lying on the floor at home waiting for an ambulance, and therefore the impact of Category 2 response, ambulances trying to get to these patients, is hugely important. I'm a firm believer in the triumvirate of care, where senior doctors, senior nurses and operational colleagues come together. And so the cell that we've now got that looks to address and understand risk and say, so what is the next thing that we should do, has now been meeting regularly, and it's allowing us to objectively measure where risk is within the system. And indeed, when you work through with some form of methodology, highest risk is sitting at those out in community, very high risk held within our ED departments, quite apart from the awful experience to patients and the moral injury suffered by staff trying to work in those spaces. But how can we better share that risk in order to take it down in those most pressurised parts of the system? How do we make sure that our teams, who are working really hard up on the wards, but making decisions around the level of therapy or support a patient might need, how can they perceive the role that they should vitally play to help decompress ED when at times they have real intense anxiety that their own professional registration is at risk if they discharge someone too soon and they bounce back and are readmitted. So our ability to get into better sharing risk requires that triumvirate to drive those changes through. Step one, we formally measured what that risk looks like, and now it's how we share and mitigate that risk. So the stepwise plan is that we take that into one of our single organisations to test that through rapid cycles of change and improvement, working with just one of our trusts. That then goes up to entire system, and it's been interesting conversations I've had with the national team have shown there is intense interest in this. When I raise it at a national meeting, every system has the same challenge in this space, and therefore we are looking to lead the way as to how we better share and manage risk across systems, and we will keep board informed as to not just what we learn, but how we make this stick to share risk in times of real trouble. So as we emerge from this winter with much that is learnt, all of this is being rapidly constructed and put together. Thank you, Chair.
Thanks, Ryan. Can I seek any questions, Paul?
Just on that point, Rowan, there are, as you know, there are non-traditional interventions.
No, it's on. It's on.
Oh, it's on.
Just
Sorry.
get closer to it.
Sorry. Yeah, but there are some innovative non-traditional interventions for the falls risk at level 2 that are being initiated. And my research team's been working with the ICB in Stoke-on-Trent with the fire service. They've been producing some very innovative work. So I wonder whether we can have conversations elsewhere around the country to learn from them.
Just to quickly respond, Chair. Yes, and the avoidance of admission to hospital is one of the most powerful things that we can do, because we know as soon as patients come in, there's a risk of deconditioning, deterioration, loss of autonomy and agency that goes with that. So indeed, that is a focus. You will see a bit later on this morning in the data interaction work how frailty and falls is an area of huge impact where we can do that. And you will hear some of the work of the community teams in other parts of the system that are working on exactly those things. And I look forward to picking this up with you, not least in our work in research and innovation. Thank you.
Thank you. Any questions, comments? And ask when we answer. Firstly, the report is developing really well. There's lots and lots of data in here. And a lot of it is very, very pertinent to the work that we're doing and the priorities that we set. I think we're getting to a stage where the board probably needs to have some dedicated time to look at this performance report and understand how the next stage of development happens. So perhaps if we could lodge a board development day focus solely on board reporting and the information today, it's a good check in here when we need to do something. Okay, people supportive of that? Thank you. I'm going to suggest we have a quick break. People happy to carry on. We have 10 minutes, so we can all get back in at 2:30. Good.
Your report? No, thank you very much. To move on to the Church report to the Quality and Safety Committee. Just for board information, 2 safety incidents reported just to provide assurance for the board, both are undergoing the appropriate governance approach. In one instance, trustees undertaking its own thematic reviews, and the second one, due to the complexity, we've enacted an emergency services for just to pick up on Graves' earlier comments on hospice provision, we've looked at hospice provision to successive quality committees. We've identified a variation in funding arrangement. We've identified variation in the way we support and quality assure the provision. Just for assurance again, there's no indication that any of these services are any concerns about the care provided, but our concern remains is that the service provision in this section is being fragile and keep it under regular monitoring. Can we just ask also that the board notes the recommendation to approve the change terms of reference for the prosecution?
Thanks, David. So any questions on the comments before we go to the recommendation? No. Are people happy to approve the recommendation? Yeah, very good. Thank you, Tony. And Remcom, Tony?
Yeah, just one item there for noting on the remuneration committee, which was the convening of the appropriate governance around appointing the chief executive. That's progressing well as set out in the report. Thank you.
Thank you. Any questions or comments? Thank you. And as the audit committee, I think that's actually Neil rather than Tony.
Thank you, Chair. Nothing to report. The paper speaks for itself. Everything's on track and we're doing well. Everybody's working now, so nothing special to report. Everything's fine.
Thanks. Any questions for the Chair of Audit? Thank you. Erica?
Primary care, so the meeting was in December. I do want to say that there was quite a robust discussion about primary care workforce pressures and how they are managing that. We've got new key standard items coming into our agenda. So primary care digital strategy updates will now be a regular item. So will strategic stakes be a regular, and freedom to speak up. The process is in place as well. I won't go into it in detail because Temmie's going to talk to us about freedom to speak up. Final one is a review of the current access, primary care access. And what will be interesting is Health Watch is coming to primary care in February, and I think to board in March with how it feels to our residents and our citizens against what our metrics are telling us.
Thank you. Any questions or comments for Erica? It's good to hear the progress that's being made in primary care committee. Yeah, thank you. Yeah, Hillary, I should have given Hillary's apologies at the beginning of the meeting. I didn't do that, so apologies for that. There's a recommendation in this paper. Chris, are you okay to lead on this paper?
Yes, it was about the terms of reference. About the terms of reference we've had their annual review. So it's the committee recommends that the board approves the updated terms of reference for the Women's Health Services Committee.
Any questions or comments? And can I seek your approval for the terms of reference amendments? Yeah, thank you. Ruth, Transformation Committee?
Just 2 things to highlight. We had a detailed update about the work progressed on specialised commissioning around some key disease group areas, but it really became obvious the importance of trying to look at whole pathways from low-level care through to the specialised, and the real opportunity for the ICB to have an impact on access to outcomes in that regard, and also to note the ongoing work around looking at where we are with integrated neighbourhood health and the current position of community services and the work that's been done to give us a good baseline to develop our plans for the future.
Thank you. Any questions or comments for Ruth? To receive that report? Thank you. And finally, in terms of highlight reports, is the report of the HCP. I might ask Claire to talk to us how welcome actually at this meeting. Claire, anything you want to highlight on this?
Apologies. No, we just had a really good presentation from both of the police and crime commissioners, which I think really exemplified sort of the partnership working, and they're obviously key members round the table at the committee, but I think it's really helpful to see and understand the opportunities of how we can work together. So that's something we're going to sort of build into future work. We launched the Health and Housing Partnership, which we're really pleased with progress around that, and that covered a whole range of areas. And then we received the draft green plan, which will be coming to board, I think, in March. There's a wee bit more engagement, but it was received by the HCP and commended, so we'll just move that through the sort of internal governance processes. So it was a good meeting, so thank you.
Thank you. Happy to take that as read. Any questions or comments? Thank you. So okay, I think you're leading this NHS Cheshire and Merseyside Freedom to Speak Up update, and Tamateo's to talk to us about it.
I don't think I need to read anything with Temi. I'm going to hand
Okay.
straight over to Temi.
Temi, over to you.
I think it's over to
welcome.
Chris.
Yeah, can I just introduce the Chair? Thank you. And then I'll hand over to Tanteo for any areas which we'll focus on. So this provides an update on the freedom to speak up within the ICB. You'll see within the paper that NHS England had outlined the expectations for integrated care boards and systems in relation to freedom to speak up, and working with the National Guardian's Office. You'll also see there within the paper that we were advised that arrangements should be put in place for our system partners in primary care by 2026, and that work's currently underway with our ICB and primary care to provide assurance around this area, and it details further in the report about how we're doing this. And so updates are provided regularly to through our People's Committee and the Audit Committee. And also you'll note within the report that the ICB submitted a self-assessment and reflection tool that was completed in January of 24, and the action plan following that completion of the self-assessment is attached within the paper. We have to repeat that assessment every 2 years, so the next part of that is due next January in 2026. You'll note from the report there's been a number of key areas of improvement that have been identified and actions that have been taken, and some good progress with developing the internal arrangements, and clearly since we appointed Tenteo into the role of Freedom to Speak Up Guardian, we've seen those arrangements develop further within the organisation. You'll see from within the report that the reporting currently at 24-25 is that there's been 29 Freedom to Speak Up requests that have come through, and having previously reported to last year's board that there was none. So they have increased steadily since the recruitment of Tenteo into the post of the Freedom to Speak Up Guardian. Within the report you'll see where the numbers that have come in Q1 and Q2, and where those cases refer to concerns around patient safety or quality, or the numbers of cases with an element of the worker with concerns about their safety and well-being. And you'll see on that appendix there, you'll see the numbers are higher within the numbers of staff worker around safety and well-being. Clearly it's our vision that everybody, regardless of their role within our organisation, has a voice and feels able to speak up and speak safely and raise a concern with any matter within the organisation. And also you'll see there about the reporting arrangements that we actually have. There's quite a lot of detail in the report that contains the action plans and the next steps and progress that's going to be taken forward. The
assessment that we do within the organisation. I think we've been doing that for the month of January, and it's due to close tomorrow, the 31st. Yeah, I thought it was the 1st of February, but it's the 31st. And so we've been pushing with staff within the organisation to ensure they complete that. Clearly there's a rollout of within the organisation of training around freedom to speak up, and that's training for our managers and training for our senior leaders. And you'll also see within the report there's a requirement within board level as well. So I think we've got a session planned for the month of February. And so that was really all I wanted to raise within the report. I'll hand over to Mateo if she wanted to just highlight any specific areas from the report, Chair.
Thanks, Dick. Thank you very much, and thanks for allowing me to share what we've done so far. So the ask from the board is to note the FTSU arrangements that we have been able to put in place, and also the progress and the reporting routes that we've got through the audit committee as well as the people committee, and also the Freedom to Speak Up action plan, which was developed as a result of the January 2024 FTSU self-assessment reflection tool, just like Chris has said. I think something that is worth noting is that we're looking at making it clearer to our staff the different routes that is available to them to speak up. And you mentioned about technology and digitalization before, Erica, as well. So we're looking at this option for staff to utilize technology in being able to speak up. So it's going to be like an icon on the desktop, which we're working with NLCSU and the comms team and the IT, so that people can actually use that by clicking on it and speak up about anything, make suggestions, whether they want to do it anonymously or they want to do it non-anonymously, because what we find out that the FTSU anonymous form, the MS forms that we currently have on our FTSU page, people still having difficulty using that. So this is going to be, a step forward in actually making it more, open and practical and realistic for people to be able to use. So I do just welcome, any question, and for people to just note, what we're doing in terms of making our working environments a psychologically safe and a psychologically safe environment for people to speak up and to raise any suggestions that they might have, because that is how we can make improvement and make it a better place for everyone, really, and also provide good patient care to the public. Thank you, Chair.
Thanks. Thanks, Tim. Just to give you a heads up, I'm going to come back and ask you a question about what you want from the board today. But before that, any questions or comments on this, Emma? Erica?
Just to say thank you to Temi. You can probably tell the motivation for this and her energy. Since she was employed by our organisation, she's done both virtual, you've been out on the road, haven't you? And we've seen that in the increase in the number of people that have come forward, because these are continuous learning opportunities for the organisation. And I think prior to starting, I don't know if we had 0 or we had 1, something like that. So thank you from me for what you're doing. I think you're a great ambassador for it. I think we also have to realise that Temi is a limited resource from NHSE. They really would like us to look at 3 things: our own organisation, which I think we're progressing really well. They would like us to look at primary care and support primary care. You can see the size of that and what that means and what we can do with the amount of resources we've got, but also be there to help and support the wider system as well. So I think we've also got to realise it's a very limited resource that we've been given, and what can we do with that. But thank you, Temi. Thank you.
Thanks, Erica. Any other questions or comments on this? Alison?
Thank you, Raj. Thank you, Temi. I want to say a couple of things. I want you to thank Temi for her visibility. I think she's connected really well out with us and is regularly out in our offices. That visibility, presence, talking to staff, engaging with them, I think is really important, and it's part of why we're seeing that increase. I think there is this is a public report. I think that just this report in and of itself, I think it's really important we take that back, and the themes are really well presented, and talk that back with our teams. because I'm sure just doing that will help develop some of the things that you've put in your report, so thank you.
Thank you.
Thanks, Alison. Claire?
Thank you. Just to echo thanks, and also you did come to System Primary Care Committee, didn't you, just at the end of last year, and I think it's a huge challenge for primary care that Eric has mentioned. We have 2,000 primary care contracts, and how we achieve this is going to be a real challenge. So we need to, work through our local representative committees and our primary care networks, contracts and sort of PCNs, whatever gathering of clinicians we have. So we've got various primary care individual contracting meetings and as a whole, and we're taking it forward through that. But I just want the board to sort of recognise it is going to be a huge challenge with that number of contractors. But we'll try and do it through, we'll manage it through System Primary Care Committee. But it is going to be a challenge. But thank you for the work today.
Thank you. Not that I can see over there now because I've got this Okay, so let me just make a couple of comments. Firstly, again, thank you for all the work you're leading here. It's hugely important to us. And this question about the additional asks being put in by NHS England into this very limited resource, as Claire said, we have to think very, very carefully about what we can do and what we can't do. Because we can't, it would be folly of us to water down the really effective work that you're currently doing, because we need to spread ourselves thinly. But we need to seek to understand what are the avenue channels that we could use to support primary care. In the action plan, my assessment is the biggest challenge we've got is around culture. And it's really good to see that culture change programme being linked in with our OV leads. And I don't want to understand, perhaps from you and perhaps in the future from Mike, what we're doing around supporting team leaders or managers who are so vital to developing that culture in the right way. Any initial observations, Tammy, on that? And then something, what is it you want from the board, if anything, at this moment in time?
Well, first of all, I'll answer the question and then I'll ask what will be supported in terms of the freedom to speak up process. So in terms of what we're doing to support our managers, and you're very correct, Chair, in terms of the managers are the one that will help us to make freedom to speak up business as usual, which is a strapline that the National Guardian's Office has on their website. And that's why we're rolling out, as Chris said, the Listen Up, which is a specific e-learning for managers, line managers, and the follow-up e-learning at TSU training, which is for senior leaders, like yourselves. Because what we found from the theme that is also highlighted in the report is most staff that do come to speak up, they have actually tried speaking to their line managers before. And maybe because they've not had any feedback or they say no to us in an action taken, which is why they're using the alternative route, which is freedom to speak up. So equipping our managers through this e-learning for them to know what is the requirement according to the National Guardian's Office will enable us to be able to hopefully make that possible in getting closer to speaking up business as usual. And then in terms of the ask to help support that will be within different directorates, if that can be echoed for managers to ensure that they do complete this e-learning training, and for senior leaders themselves to do the follow-up e-learning training, that would be helpful so that when staff are speaking up, they know how to actually support them to ensure that the realistic practical outcome sought is achieved, and that will enable us to be able to create that environment whereby staff can help us to sense things before it actually gets out of hand, and we can improve our FTSU culture that way and the organisation as a whole. Thanks.
I guess, Mike, there's a way of mandating the training for managers.
So I think what's really important is that freedom to speak up is in addition to all the things within the organisation. But it's a chance for us to reset some of those, come together as an organisation, it's a chance to reset and some of the policies, and if all that's clear and aligned, then you can help train managers to be clear on what's expected, because fundamentally it's about an open culture. That's all it's about. And the NHS has for decades had initiative after initiative, pre-Freedom Speak Up, about how it talks and communicates with its own staff. So it's just, so if we get the building blocks in place, we're talking about some back to basics stuff. Get them, you're quite right. Certainly I'd be wanting to ensure that all line managers have some, are clear about their role, and then the Freedom Speak Up starts to sit on top. Because some of the stuff is very basic, isn't it, Tammy, and some of it's not. So we really want to take the straightforward stuff out of it and get us to the point where Freedom Speak Up is really picking up those key issues where people feel confident to speak. You can't drop this in an organisation that's not got a fully open culture.
Yeah, I just wanted to add to that as well, that we already have the core e-learning Freedom to Speak Up, which is embedded within the mandatory training on ESR, and we have 90% of staff who have already completed that. But just like I said, from the themes of what we've had since Q1 to 3, it's essential, that the managers themselves are skilled to listen and take action, which will help, like you just said, to make it even better. Thank you.
Good stuff. Thanks, Tammy. So the paper's here for noting, but also to endorse the updated action plan. Are we happy to endorse that action plan, comfortable with that? And it requires us to do things as well. Yeah, thanks, Tammy. Thank you. If we could go on to the where you're leading on the assurance framework.
Yeah, I'm going to introduce it, and then Matthew might want to come in, and obviously colleagues around the table who are the executive leads for the risk. So you'll remember that I brought the 2024-25 BAF and principal risks to board in July, and they're approved. We have 10 principal risks, and currently scored as 1 critical, 5 extreme, and 4 are high. 7 are currently at their agreed targets for this year, while 3 remain above the target for 24-25. So we are suggesting that it's likely that P3, the lack of urgent and emergency care capacity, and P5 around acute and specialist providers achieving the backlog for elective and cancer waits won't achieve their targets in year. So we're recommending that those target scores are increased to 15 and 20 respectively. Since November, P3 around financing, around finances and the ICS's ability to achieve the statutory duty has been reduced from critical to extreme, but I know there have been conversations, and I know Mark will want to come in on this, as Erica may want to, because that's one of the key changes from November, but colleagues may want to come in to discuss anything else around the risks and the BAF. And then finally, Q4 BAF will be presented in May, which will complete the year for 24-25. And we'll also look to present the new BAF for 25-26. And so we want that to sort of form the framework for our board development plan that, again, we talked about earlier, saying will come to board in May. So I think it's important that between now and then we start working on the BAF for 25-26, as well as completing Q4. But I know, Matthew, you may want to come in, if that's okay, Chair, and Mark in particular, around P7. Thank you.
Matthew?
I think Claire's covered absolutely everything I'd written down to raise, to be fair, other than just to reiterate to board members and anyone else reading the paper that the appendices to this paper does show that the main programmes of work that are looking to mitigate the risks that we've highlighted. So whilst the cover paper gives you the key headlines, the devil in the detail is in the appendices as well, and it's good to scrutinise that, and happy to answer questions or seek colleagues around the table to answer any questions on any of those issues in there.
Okay, thank you. Mark, should we go to you first?
Thanks, Chair. Thanks, Claire. Yeah, so I think how do I start this? I think hindsight, wonderful thing, start with that phrasing. My suggestion is that the risk description doesn't necessarily help us to be clear about the risk scoring on this. It would appear that there's a bit of a mixture of ICS, ICB within this, and the term statutory stroke break even. So again, just a bit of a recap from my understanding is the ICB obviously has a statutory duty to break even. We're not at risk at the moment based on our forecast of breaching that statutory duty. Provider trusts in that context, they don't have the same statutory duty. Their statutory duty is to be a going concern in terms of their sort of financial position. And that is usually judged over the longer term, not an annual cycle. Again, we've referred to that today. There is something in the technicality of going concern, and again, what the nature is of that. And I think back to again earlier comments, the regime that we're in, where specific pots of money are often given to providers in the short term, means that often auditors would sense that they are going concern in that nature anyway. So I think, again, hindsight, I think the wording could be smarter, quite frankly. And again, spoken to Erica and Matthew and other colleagues around, ahead of 25-26 BAF, we need to reframe the risks around that. I'm not seeing it trying to pretend that there isn't a financial risk, because clearly there is. But I think there needs to be a bit more to smarten that up. If I, obviously coming into this fairly fresh, if I understand it, the discussion around the risk score reduction is partly because, notwithstanding comments again made earlier about the need for a medium and longer term financial strategy and the values around it, there is a structure that has been previously presented through the organisational governance around what that would look like, and I think that was felt that would and should reduce the sort of the longer term risk, hence why the impact score was reduced. So they would be my comments. I think we need to go forwards in a more sort of constructive and articulate way, if that makes sense, Chair, but hopefully that allows us to move forwards today.
Thanks. Well, how I've understood what you've said is the thing that this script is technically incorrect, but what we do want to focus in on is delivery of the agreed financial plan, and it's that's at risk. Is that a good summation of what you were saying? And then, of course, we've got the strategic risk as well as the in-year risk, two separate things. So are you reformatting this risk statement into a place where that follows what you've just said?
Yeah, so working with Matthew, we've talked about what we need to do for Q4 and then what we need to do from April onwards, and absolutely that would be the plan.
That's helpful, thank you. Because it was a puzzle to me to see how these things could be reduced. Anne?
Just to comment on the elective care one, it says it's got a likelihood of 3 and an impact of 5. I would think it's got a bigger likelihood and a smaller impact. So it probably should be more like 4 and 4, or 5 and 4, because it won't happen. There will be some waiters left at the year end. It will be, there's some trust I can't really do it. So it will be a small number, but it will be a number, a very small number. But the impact is not as great as the urgent care impact in terms of patient safety and harm, and it shouldn't be the same score.
Yeah, are people happy to accept that? Yeah, thanks, Anne.
Thank you. And we'll make those amendments, and we can obviously review it for Q4. I think it's just helpful in terms of the feedback, and I think we just need to think about a mechanism where we sort of review this. So obviously we take it to audit committee, but we need to go, I think, through speak with you, Anthony, in terms of sort of the quality and performance side of things, but also take it through CMAST. Because I think we get that sort of slightly different lens and slightly different conversation. I think it's important in terms of pulling that part of the ICS into sort of some of that assurance, so we can do that going forward. Thank you.
Thank you. So just an overall comment from me. I think this is maturing nicely. One of my tests is it informing the board agenda? And I think it is informing the board agenda, so we can get some big ticks there. So well done, Matthew and Claire. Thank you. But there's some really good suggestions. There's Mark's suggestion about reframing the risk, and Claire enabling CMAST and the other collaborators to give us some views would be really, really helpful. Thank you. Be happy to move on? Yeah, thank you.
Okay, so I'll summarise again, hopefully give Matthew a bit of time, so I won't go into too much detail. So just to remind the board that the corporate risk register is made up of risks escalated from committees and directorate risk registers with a score of 15 and over. The 15 risks are detailed in Appendix 1, and as Matthew said previously, there's an awful lot of information there, so please do have a look. We have 4 critical risks and 11 extreme risks. They're summarised in 2.2, and a slightly longer detail in section 9. And just for those eagle-eyed of you, and this was me last night worrying that we got our numbering wrong, there are actually 2 risks covered in 9.1.14. So 14 covers risks 14 and 15. Since November, obviously I bring this report every time, so since November, there have been a number of risks being escalated via quality and performance, and 2 further placed risks which will be reviewed by quality and performance at its next meeting, and you can see the details of those. So I wasn't going to go into too much more detail because you can see the detail there and you can see the risks that have been escalated. But really I want to just confirm with the board whether this is enough information. It's lots of information, but is it enough? Am I giving you enough assurance there? Thank you.
Okay, thanks. Any questions or comments? Speak to Claire's asked. Is it giving you the information that you want? That's a tough question to answer, I think. So you don't know what you don't know.
So, I mean, can I just say, Chair, please, obviously as we develop the BAF for 25-26, clearly the corporate risk is all aligned, and I do hope that we can, through, because I know we've got a conversation with Mike and myself and Matthew around board development, and obviously with yourself, Chair, in terms of we need to really get into sort of the risk appetite, building the BAF and the corporate risk. So I think that's something we need to try and build in as soon as we can, because obviously this will drive, as you said, the board agenda and the board development plan. So I think it's really important that we have those conversations, and maybe at that session we can sort of have a bit of a debate about the level of assurance. Thank you.
Thank you. Matthew, is there anything further? Warren?
Thank you, Chair. It was just on for some of the risks, the Strategy and Transformation Committee is responsible for them. So if there's a review around whether that exists or doesn't exist, we'll make sure that they're picked up somewhere. I did note that the ACP was included in the kind of formal list of committees reporting. So whether it's there that they're picked up, it needs to be reflected in the ICB structures, not just palmed off. There's some key ones. And
yeah, very good point. We'll make sure that happens. Okay, so if we're happy to move on, I think Anthony.
Thank you, Chair. So hopefully the paper is pretty self-explanatory, but just to pick out some of the issues and some of the context and next steps. But equally conscious that we've probably covered some of this ground at the most recent board development session, but I recognise not everyone was there. So just in terms of the status, on the 6th of December, or sorry, 6th of January, a Reforming Elective Care for Patients publication was made, which set out some of the expectations in terms of timescales for improvements against waiting times. It should be noted that the publication of that paper was before the release of the operational planning guidance and also before financial allocations were known. But what it did set out was a timescale for a return to NHS elective standards by 2029, which was in line with the government's manifesto pledge in the run-up to their election. What's of note is it signals a return to referral to treatment measurements, i.e. those percentage of patients receiving treatment within 18 weeks from the date of referral, as opposed to the approach we've seen in recent years, which has been one of eradicating long waits since the pandemic. So the initial assessment of that ask in terms of the forthcoming year's expectations of delivering this 65% RTT performance is that we currently sit as a system at 57. And within it, it has a clear expectation, even if one part of the system, one trust, is delivering that standard already, there is still an expectation that they will see a 5% improvement from where they currently are. The maths of that is that, initially based upon our weighting, the size we would need to see a shift of circa 43,000 patients on the waiting list. Now, if I put that in the crude context that last year we saw a change of 7,000, it appears at that stage to be quite a daunting ask. But I guess that's why it's called an elective reform paper as opposed to an elective activity plan. You know, it's clearly reading across to the ambitious aim to improve productivity and efficiency, embracing new ways of working and engaging with inpatients throughout rather than a simplistic activity target. Nevertheless, it is considerable, but not one from what we can see where C&M would remain an outlier. So within 7.1, there's a detail around some of those different ways of working. CMAS have been working very well in this arena even since before the publication of this paper. So some of these opportunities are already in train, and we would hope to see them panning through in terms of tangible benefit next year. But over the past couple of weeks, CMAS have been taking down that opportunity down to a granular level of opportunity and all of a realistic expectation over the forthcoming year, and we're trying to almost work how we bridge that gap. One factor that we're clearly aware of is the ability to deliver that is highly dependent on the financial allocations, and while some of that is still not entirely known, we are expecting that the cap on the URF, which is already in place, is likely to continue into next year. Indeed, we probably expect an overall elective fund to be somewhat lower than what we're already incurring. So again, it points to different ways of working. So I will hold there. What I'd say is that at this point in time, we are incorporating all this approach into our planning timescales. We'll be taking stock today on the detail of the operational planning guidance, which I understand has been published, and I shall have it in me tonight. But it needs to be in the context of both the affordability and the deliverability in terms of this, and we'll fetch something back to board, obviously, as part of that wider process. But what I will say is we'll absolutely take into account the board's previous commitment back in September to trying to do something around children's and young persons' weights ahead of what we're doing within adults. So we'll make sure that that's still, that commitment is still there. You can see, going back to the IPR report, that we're making progress on long weights for children ahead of adults. But we'll bring that together as a rounded part of the overall plan for discussion and improvement.
Thanks, Anthony. Any questions or comments?
Yeah, as the person that Anthony's just delegated all of this to, can I say he must accept the delegation of this responsibility to do the best we can on restoring our elective performance to where we'd like it to be. I suppose just a few things to mention, but just Anthony mentioned the financial thing. That is a really big one because obviously, in the past we've been able to assure providers that if they do extra activity, they will actually be financially remunerated for it, and taking away that assurance is going to be quite a big one in terms of the ability to both balance the books, to acknowledge all of the financial pressures we've just talked about, but at the same time we want to treat as many patients as we can. So that's a really big change of message that we're giving out to our providers, and how they receive that will need to be managed. That leads us into, we need to be better at productivity. So one of the things that we are particularly going to be focused on, we've always been focused on productivity, but it's just got to be even higher up our agenda in terms of we've got variation of performance between our different organisations, and we need to get everybody into the best place. They've done a lot of work on that already, we need to do more on it. We've got a meeting with GERT next week to go through what they perceive to be our opportunities. There's always some gremlins in that, but there'll be some good ideas, lots of good ideas as well. And we've also got all that comparative information that NHS England has produced, which will be forensically analysing to find out if we're going to put our effort in, where will we get the best consequence of that effort, because there's no point in trying to do everything. We need to do what will make the most difference. And then CMAS also does some work on pathways, so the transformational side of pathways. So again, they don't exactly mirror the same specialties that NHS England have highlighted. Seamasters generally chosen its specialties on the back of having particularly long waiting lists and or particularly fragile services where we've got huge vacancies, and there are some specialties that really across the whole of Cheshire and Merseyside would fall into that category where nobody's got the capacity, in other words. So just shifting people around between one trust and another won't achieve it because the capacity is just not there. Now, that doesn't exactly relate to what our local priorities, if you like, Cheshire and Merseyside's priorities, but the government have also listed a whole other set of things. So we'll just make sure that we can, make sure that there's anything else on the list that we give it some focus. So that's where we'll be. It's a big ask to move to the shift that Anthony's just described in terms of just how much extra productivity we need to achieve to deliver it. But we'll be doing our utmost to try and get as close as we possibly can to that aspiration.
Thanks, Anne. Could I ask you to give us an indication of when you think the plan can return to this full costing plan? And
well, so we've just been making planning guidance really. We've done all the kind of background analysis, and we just need to see what the planning guidance says. So I think, where are we now? It'll take probably a month or so, but no more than that, weeks to just firm that out. We've done all of the background stuff you can do with what we know so far. We just need to understand what the planning guidance actually comes out and says in the end.
So, March. Yeah, March. Thank you. Rick? Sorry, I've got Steve and then Rick.
One of the say may not be totally realistic, but the concept of linked theatres, things like that. I mean, is there really a determination to move this forward, or is it we're going through a process which NHS seems to like and developing plans? In other words, I'm going to see some real action on this.
Well, I said in a very negative way, Steve, but actually, I'm going to give a comment.
Generally, our metrics are very good in terms of the national comparison and the national aspiration. So, there is a bit of headroom for us to go at, and we've got really great clinical engagement between our organisations. So, if someone's cracked out to do something, they're always ready to share it with everybody else, and everybody else is ready to listen and learn. So, we just need to. We've done loads of work on this already. We've gone, much improved productivity already, but there's more to do, and we'll certainly carry on doing it. But we're certainly not really in a bad place if we do a national comparison with everybody else in terms of these kinds of metrics. We're reasonably good at most things. Not saying we can't improve.
And perhaps it'd be useful to just to give the board at some point in time a bit quick review where we are against SCARF indicators.
Yeah, I've got a whole page in this very pad on exactly where we are in every metric on GERF, but I won't bore you all with it now, but it's there.
Okay, thank you.
Thank you. Obviously, timely care is a crucial part of a quality service, so I really welcome the effort that's going to go into making some improvements. Some of the recommendations from NHS England talk about advice and guidance, alternatives, different settings. And what I'm concerned about is that we need to have a clear eye on patient-reported outcomes. We can do lots of things, we can do them quicker, but did they actually achieve what the patient is hoping for? So in our determination to improve time of access to services, I think it's vital that we're also guided by did the treatment actually achieve what the patient was looking for. So there are many parts of healthcare systems that really pay close attention to patient-reported outcomes, and I just don't see that focus in this. It's all about, can we just see more people, basically, and get more treatments done, which is really important, but we need to know treatments and they produce the right benefit for people who are accessing services.
Thanks, Ruth.
I think the other thing, Ruth, is that we make sure the right people who get treated, not just the right outcomes, because one of the things that's absolutely listed among some of the information we've had so far are things that will actually increase health inequalities. So we've got that other issue as well, you know, things like PIFU, things like using digital apps, things like choice, you know, they run the risk all of increasing health inequality. So given that is our biggest thing, isn't it? And we keep saying that's probably our number one thing. There's lots of things in this that actually aren't great from a, you know, promoting health inequalities point of view. So as well as making sure we treat the right patients, you know, the big dilemma is that thing where you don't treat people in priority clinical order, you treat them in time order. You know, you've got, that's another, now we haven't even gone anywhere near that in the past, but I do wonder what might be said in the planning guidance about that, and that would be a major issue.
Thanks. I guess if I could just capture the point that's being prompted by Ruth and Anne, we do need to understand that the totality of the impact of the NHS developing health inequality, patient-reported outcomes. I am not sure where we see that or how we could see that. So I'm looking at Anthony because you a performance. Is that something that you could give some view to with Rowan and Chris, obviously from a clinical perspective, not today, but as we see the report in March, let's understand what we can reasonably do about understanding that balanced scorecard, and we'll call it of indicators. Right, I'm going to push us on because Graham is very quick. Was it a question, comment on that?
Yeah, it was.
Very quickly.
Yeah, very quickly. So, thank you. We have now taken the first 1,000 patients, very high-risk patients, through prehabilitation with really startling improvements in their clinical outcomes, and vitally to the issue of both health inequalities. They are from the most deprived backgrounds because they live with the most comorbidities. And for the first time, the paper is being prepared now, which reports that a digital-first approach to prehabilitation does not worsen health inequalities. The uptake has been precisely the same across the groups, and that's not been reported before. A lot of patients are saying, you know what, I didn't have to go to the hospital and get 3 different buses. This has worked really well for me. So I think we can increasingly demonstrate that we are working really well in that space. Thanks.
That's a great piece of the puzzle, but let's see the totality of the experience of patients and as we strive to reduce access times. Graham?
Thank you. Just to partly address the point on patient-reported outcomes, the English NHS have been using these for a very long time. The most obvious and the most prominent one is associated with knee surgery. And the data is still collected and still available. We're going to be really careful about just putting another data line into the performance report. Just makes the performance report feel bigger and not receive our attention. One of the things that the elective recovery team under the leadership of CMAS are doing, which I think is really important, is they are looking at area by area the way we have used referral management. And in some cases we've used referral management as a purely patient support process to help them navigate the choice agenda, but in other areas we have used referral management to effectively put an extra step in the process to ask the question, are you sure that the right disposition for this patient is to surgery, for exactly the reasons that Ruth talks about, in terms of, you know, the answer shouldn't always be straight to surgery in situations. So I know, because I have asked, that you know, the team are looking at standardising our referral management arrangements first and foremost around ophthalmology, but actually we should ask them, and by way of now, to also be looking at strengthening and standardising those referral management arrangements around orthopaedics, because I think that is the first place that we should look and take some of that learning that comes from POMS data that perhaps we've lost, you know, in the melee of everything else that's going on. The other thing that will come out of the elective recovery plan or the planning guidance, which I'm absolutely certain has been published while we've been sitting here, is a requirement for transformation plans around 5 named care pathways. And as I sit here, I can't remember what those 5 named care pathways are, but again, I am asking Anne and the team to introduce a 6th local transformation care pathway for Cheshire and Merseyside, and that is gynecology. And again, as Anne has told you, the team have been all over this data for weeks. Now, we have a new targets that in the planning guidance that is set for this coming year, but we know what the government's ambition is for the end of this parliament. And this is the point that people keep making, is getting into a long-term space. If we do not do something significant and transformational in gynecology, we know, as we sit here today, just by doing more of the same, we wouldn't hit the target by the end of Parliament. So it is being well led. We are kind of all over this, but we do need to see it in the context of the whole of our plans as well.
Thanks, Craig. Naomi?
Just while we're talking about, we've mentioned advice and guidance, and obviously Graham's talking about referral management. From a general practice perspective, we were really pleased to hear that general practice will be funded now. It's £20 per advice and guidance from next year. That's part of the new budget. However, there are concerns that have been raised as to whether this will actually mean that general practitioners are now expected to manage complex medical patients that would usually be managed within secondary care. Within general practice, the narrative is that we would happily support reducing inappropriate referrals. We're happy for any education. However, we also need to ensure that when a patient requires referral, that they are referred to and accepted by the appropriate departments. So again, I suppose it's going back to that, it's the management of clinical risk. And £20 does not cover complex investigations within primary care, nor management of those patients there.
Really, it's a really good point in terms of, and I'll describe it in this way, we shouldn't be squeezing the balloon at one end for it to pop out the other. Absolutely, and that whole system approach is really, really important. So having that balanced scorecard of indicators, that allows us to understand the totality of the impact of this. It will be a huge initiative. It's going to be really important to us. There are other things that are required of the ICB that are in the appendix, and say, like choice and things. Will we receive a report about the plan on implementation of those soon as well? Thank you. So, any other questions or comments if we can move on? Thank you. So, John, Cyber.
Thanks, Chair. So you've had a paper in your pack which was a response to, colleagues may remember the last time we met in Chester in end of November. We were just feeling the first rumblings of a live cyber attack in one of our trusts, and it was the first of 2 in quick succession, which ultimately we believe were unconnected and were quite different in nature, but colleagues asked for an update on our system-wide cyber strategy and progress in terms of the various resilience measures that strategy outlines in a aspirational plan. So I'm just going to talk briefly about the programme and some of the key objectives and some of the challenges around that, particularly funding, but then just pick up some learning from the 2 incidents and reflect on how that helps us refocus our priorities in the immediate term. So just to remind colleagues or just emphasise the ICB's responsibility around cyber across the system, and we do have some responsibilities that are set out in the National Cyber Strategy for Health and Social Care. There are 5 themes to that national strategy, which are focusing on greatest risks and harms, defending as one body, people and culture, and getting our understanding and attitudes right around the threat, and then building and designing things for the future in a cyber secure way. And a really important fifth component is how we respond to the inevitable incidents when our defences are breached, and they always will be, because it's a bit of an arms race. As fast as we build defences, the threat actors build new ways to attack. So we have got some responsibilities, and we've got a programme designed and with detailed deliverables in that delivers against the strategy that was approved at board last March. We were successful in securing, or notionally securing, 2 sets of funding from National Cyber Resilience funding this year, but ultimately, and disappointingly, neither of those pots of money materialised. They got caught up in some of the financial challenges and capital to revenue transfers, I think. So the funding, the rate limiting factor on progress is how we fund some of this work. However, we've made some real progress in year, particularly around incident management protocols and how we organise ourselves to respond to an incident. We've jointly developed a comprehensive incident response plan with our EPRR colleagues, and I'm delighted to say we're working really hand in glove with that team. It was tested almost immediately. We rehearsed it in full-day workshop, and shortly after that we had the first of these live incidents. And that was one of the pleasing things, that plan stood the test of a live incident. The biggest issue, so we'll progress with the plan based on the limited bits of resource we've got. We're hopeful that the promised funding will materialise just the other side of the financial year and allow us to up the pace of delivery again. But the big component of that I think will move us on significantly is the creation of a small core team in the centre of the system that will manage some of the assurance and also manage our response in terms of incidents. So there's a debate to be had whether we should be relying on national pots of funding to stand that capability up, or whether we should be looking more inwardly around our existing resources and reorganisation. If we just go on to the 2 incidents, and I won't go deeply into the root cause because at least one is still a live incident, but they were different in nature. Quite often, cyber attacks can be categorised in a number of ways, but quite common is the malware, which is applied to a host system and sits there, and the threat is encryption and removal of service. Another typical type of incident is where the threat actor gains access to your systems and removes data, and either publishes or demands ransom, etc. We had both of those incidents in effect, and very different in impact. So in Wirral, the threat, or the malware, was detected very early, and the Trust's business continuity processes kicked in. Well rehearsed and well planned, and I think that saved a lot of disruption in the long run. So there's a key lesson there around all trusts being prepared for the inevitable and having well rehearsed processes to fall back on in the absence of digital solutions. The other incident, which impacted Alderhay and Liverpool Heart and Chest's shared infrastructure, was different in nature. That was where the threat actor got onto the network and removed some data and published a small set of data on the dark web with personally identifiable data in. They're still working through a forensic piece of work there to understand the extent to which data may or may not have been lost. So that's a live sort of piece of work. Regional colleagues are running a formal recovery programme, and there'll be lessons learned that formally get driven out of that. But reflections from me based on the work we've done, there are a number of key bits of learning that I think the board should be aware of. As I say, our incident plan was very effective, but we just need to clarify responsibility at the boundaries of that plan. What's the role of region, what's the role of the national colleagues, and where does the ICB support individual trusts, and we'll refine that with all the various stakeholders. We still need that core team at an ICS level, but again, we need to work with national to understand where their service offer stops and where we need to create a complementary service. There was a piece around communication. The national team parachuted in this National Cybersecurity Operations Centre, and we were pleasantly surprised just how comprehensive that support was. Multi-agency response and comprehensively took over incident management. Their approach was a news blackout, and there's some learning from that in terms of the behaviours, the unintended consequences of not sharing bits of information. Some of our system suppliers turned off access to key systems unilaterally to protect their own infrastructure. So there's an ongoing discussion around a balance of information sharing and not giving the threat actor any indication of how well you're responding to the threat. Big theme was just how interlinked all our organisations across Cheshire and Merseyside are, particularly our trusts with shared infrastructure, and often clinical users from other trusts reliant on systems provided by another organisation. So the takeaway there is we absolutely have to think, plan and defend as one, but treat our infrastructure as one coherent architecture. And just some food for thought, we're moving into a world where we're increasingly providing big shared systems. I'm thinking around our PACS imaging system, our new laboratory information system, which will be delivered across 5 host organisations. Real efficiencies, real transformation opportunities, but in the event of an attack, the impact is incrementally higher and you lose more data and more trusts are affected. So our cyber provision and cyber by design has to have an equivalent level of emphasis and investment as the shiny things that we're building. And I think the solid business continuity plan on the basis that we will be impacted and we need to be able to move back and maintain services without access to those systems. In the heat of the incident and since then, a long list of good practice came out of that. Nationally, we're told that most of these successful attacks are preventable just by good housekeeping. I'm talking about things that we've spoken about, certainly in our exec team, around multi-factor authentication, the frustrations of having to verify who you are twice rather than once is a small price to pay for keeping our systems safe. And we did a live audit of each of our provider trusts' performance against a number of factors, and what it demonstrated was we've got a real mixed bag of compliance and good housekeeping, and it's entirely understandable because some of these things are not immediately apparent to go and look at. So there's an immediate learning there for us to focus quite quickly on an assurance regime, and in the absence of funding to do the big pieces of the programme, one thing we can do quite quickly with existing resource is just change the nature of the cyber conversation. So at the moment it's a community of interest, everyone comes together and shares good practice. What I'm proposing is to just change up the assurance role of the ICB and set some mutually agreed standards for patching of systems, some KPIs, and build a regime to regularly report on that and then support those organisations that need help. And it will allow us to direct funding to the most high priority areas. So that's just in terms of risk, the overriding risk is resources and funding, both in my team and but more widely to support the programme. I think hopefully both will shortly be mitigated. I think I see light on the horizon in both cases, but that's an ongoing, I guess, thing for the board to just be aware of. So the paper just asks to note the progress on the plan, the learning from the incident, and approve that change of gear around assurance and transparency. I think there's something to think about how we do that. Do we link through the provider audit committees and share some good practice? There's a discussion to be had around the most appropriate way to build that assurance, but I'm looking for sort of approval to formalise some of that role, really. So I'll stop there.
Thanks, John. Right. Questions or comments, Neil?
Yes, thanks, John. I think this is so important going forward because it's not just about systems, it's about patient safety as well when these systems go down. So I think it's critical that we look at this. I mean, I suppose my question would be, is the clarity everywhere with who does what? What's the national role, what's the ICB role, and what's the provider role? It seems to me that there's a lot of stuff in the providers which is a mixed bag, a variation in terms of a lot they can be doing themselves. Then there's a question about what should we be doing, and at 14.2 you refer to you've had a vacancy raised because of the situation we find ourselves. This needs to come out in terms of our planning, in terms of where it sits as a priority and what the risks are of doing it or not doing it. So how do we actually get this on the board's agenda so that they do their own assessment? Because sometimes I fear we go through a professional link and it's like it gets misinterpreted at the board level or they put their spin on it.
In the sort of relaunch of the programme, I've asked the CIO from Clatterbridge, Sarah Barr, who's particularly focused on this and has been reporting in some detail to the Clatterbridge board with a detailed assurance sort of template. She's agreed to lead this piece of work across all of the providers. So I take the point around doing it through that professional group. We need to think how we take it beyond the CIO conversation, because I think ultimately to get good scores in terms of housekeeping, you need to focus investment to do the patching and due diligence. So in terms of the clarity of roles and the tiers of this agenda, I think it's getting clearer, but there's still some work to do. And I had a call with the national CISO, the national head of cybersecurity, in the middle of this incident, and we agreed to reconnect and just work out exactly that. Who does what in an incident setting, but also in a planning and delivery setting.
Thank you. Anne?
So that league table thing you said about when you've looked at all the different trusts and where they sit as regards the effect of protection against cyber security attacks. Have you shared that league table with chief execs? Because that's, that CIO community, sure you'd have lovely conversations, but it'd be really good if you're running an organisation to be able to see where you sit relative to others in terms of what the art of the possible might be, in terms of where those big risks are and how well your own organisation is protected against it. Because often these things do the circulation on get with the professionals, but it's not. This is something the leader of the organisation should be bothered about and should be informed about. So if I was to ask any of my chief execs from CMAS if they got this information, would they tell me they did?
Some would, some wouldn't, I think. And I think that's what we've got to fix. Some reports are going...
We send it. You send it. Then they'll get it, won't they?
We could, and that's the proposed next steps. But what we want to do is, they're subjective scores, so we need a level of confidence in the underpinning rationale in each case. So, for example, if you use something called a Microsoft MDE score, it takes a load of measures around how well you are patching, how well you are closing down accounts, etc., etc. But depending on the time in the month that you measure that, it might be just before you do your patching or just after. So there's a level of subjectivity. So I think we just need to get a collective level of confidence in the data and then do as you describe, I think.
Ruth and then Naomi.
This is so important, and what's evident in the paper is that we're all collectively responsible. If one bit goes down, there's huge impacts, especially with the big new systems that are coming in. So it's vital that these are developed with cybersecurity in mind. I really welcome the sense that we need to have more assurance across the system, that every component part is doing its bit. I would actually take it a bit further and look for clarity about accountability. Neil mentioned the boards and what's their role. I think there's a level of, we all should be held to account that we have maintained our systems to the level that is required. And so the more clarity we can give to what is expected, and so that people are clear what they are responsible and accountable for, and that includes the boards, I think, and what we expect them to be doing. I think it's vital, because we are vulnerable if one bit of it is not doing its job.
We come to Naomi, and then I'll just make a comment on accountability.
So I suppose mine followed on from Ruth really, but particularly within the report, it's very secondary care focused, and it's to look at, well, actually, where's the responsibility within primary care, and I'm talking about all 4 contractor groups there. You know, we've got the dentist records, we've got now, you know, with Pharmacy First, we've got the patient records there. Within general practice, we are the data holders, we are the data controllers. So it's, I think we need to look at this system-wide. You know, if general practice data is attacked, that will have an impact on the entire system. When secondary care is attacked, it will have an impact on the entire system. So it's just, I think we need to look at the whole picture.
It's a really good point, and I think in terms of GP practices, some of that responsibility sits with us and through our providers. Some of the other contractor groups, it's less clear, and I think the intention in delivering the strategy is starting, and the funding actually is rooted to those providers as well, so it does skew the agenda slightly, but the principle as Defenders 1, it's wider than NHS providers, so our local authority colleagues, we have connections, and we're acutely aware of the joint risk we share there. So, in terms of incident rehearsals, we do work across in terms of resilience forum, but I think that's the next phase, really, thinking of this at an ICS level in terms of all its components. But that's an enormous undertaking and does need some dedicated resources.
Okay, so right, John, you're asking us to approve the vulnerability management plan. I think what's coming out loud and clear is how does this organise, how does this board have the appropriate assurance that things are being progressed in the agreed way, subject to findings. And important in that is a clarification of each part of the system's accountability. I do wonder whether we should ask an organisation like MIA, who've got some expertise in accountability, to work alongside you to draft, probably led by audit committees, to draft a series of management controls that can help boards and ourselves understand what that accountability is and draft up some sort of framework. Neil, does that feel like the appropriate route you think?
Yeah, because they are involved with you, aren't they, John? So you work closely with them, so you could perhaps look at a spec kind of thing and come to the audit committee with that.
Yeah, we've had some initial discussions around could we audit as part of existing audit plans, or do we need a separate audit regime? So we've had some preliminary discussions with MIA, but we can flesh that out and build it into a proposed framework.
It would be good if you could connect audit chairs forum again and just give an update with these experiences, because it was clear that they weren't aware of the risks within the organisation, so this would just help them. And maybe
happy to do that.
And with the data, I know there's the validation. The difficulty is you can keep on validating it. If you send it out and say, well, this is your data, as long as you've got the benchmarks right, I think get it out there and then get them thinking about it. Otherwise, you could spend the next 12 months validating the data.
Yeah.
Get them to validate it.
Right.
Chair, as an organisation that is solely funded by taxpayers' money, you know that we conduct most of our business in public. One of the things I would urge on this subject matter, some caution, and it might be necessary for us to transact some of this business in private. Because if we want to say very openly and transparently, here is the organisation or here is the service which is the biggest risk, because that in itself would add to the security risk we take. So I take all the points the board makes, they're the right things to do, but this might be the odd occasion where we have to take some reports in private because of the nature of what we're discussing.
Yeah. Okay. So we're seeking that approval of the management plan. John, you highlighted the risks which are around securing the funding, but you said there was light at the end of the tunnel, and that hopefully that's the case. You're happy to approve the vulnerability management plan? Yeah, thank you. Rowan?
Thank you very much, Chair. I'm delighted that both Andrew Asprey and Jim Hughes have joined us for our report on data interaction. Time has flown since April last year when the programme was formally established, and the opportunity with colleagues this afternoon is both to share some of the work that's been done, the progress and the ambition going forward, because I think our ability to use data in a sophisticated, intelligent way is a real strength of us as a system, and that's been called out nationally as well. But some specific asks, really, that we now not just embed that we see this intelligence, but that we make it the way we conduct our business as well. And we are keen for board to consider supporting that we now put in place appropriate governance across our places, so that these proactive models of care are designed and embedded as part of the way we do all of our business. And a case in point was that of complex households. So I'm delighted to hand over to colleagues to walk our board through progress made. Thank you.
Thanks very much, Rowan. Thank you, Chair. Just for introduction, I'm Jim Hughes. I work for Merseyside as a strategic advisor on digital and data programmes, and also for part of my time for the ICB as a senior responsible officer for the data interaction programme. So Andrew introduces us.
Hi everybody, I'm Andrea Asprey. I'm the Data Interaction Programme Director across Cheshire and Merseyside.
So what we intend to do in this next the few minutes we have is to take you through what we've done during 2024. We were last here at the board in April of last year, and we'll just indicate what we've done during that time, and then we'll move on to a key piece of the work, certainly for 2025, as to how we start to use the data insights that we have and additional opportunities through a federated data platform to enable an approach to strategic commissioning for the ICB, and then we'll return to the ask of the board. So the whistle-stop tour. So the whistle-stop tour is on this slide. So during 2024, we have established an appropriate governance of the board, and we now have a programme board, and we have the relevant people in place, and importantly situated in governance terms within the Medical Directorate. We've established a number of processes, and most importantly through this year, that they account for the data access processes to ensure that we govern the data appropriately. But also we've developed a prioritisation process to understand impact and feasibility, and we'll spend a bit of time on that in the presentation today. I think one of the things which is a highlight of the work that we've done is around developing the capability amongst the workforce around a population health academy, and that's something again which will be through this slide. We said we would do this year, and we have in the space of 6 months achieved something quite significant. An important aspect of the work we do is around public-facing activities and how we engage with the public, and again we'll go through this in a little bit more detail, but just to say that this is very much a kind of front and centre of the work that we do. The data is not our data, it is the data that belongs to the public that they give when they enter into direct care, and we have to be very cautious about how we use it and accountable in effect to our public. And we've optimised assets and products. Most notably things we'll look at the impact of youth poverty and enhanced case finding tool. But I think a very important step was taken when as a board, through the Finance Investment Committee, looked at a £25 million investment in infrastructure. And I think this plays to the point that Rowan made about what, if we're going to make that investment in the infrastructure, then we need to make the commitment to the products that arise. And I'll say a little bit about our stakeholders as well. We won't have the time to cover all of them, but I think things like the secure data environment for the Northwest, the relationship, the excellent relationship we have with with academic colleagues, and particularly University of Liverpool, through CHIL, and others at Place and Neighbourhood, has been quite significant, really significant. So I'll pass over to Andrew to talk about some of the processes.
Apologies, I went too far. Yeah, so as you would expect with any new programme, we spent considerable time and energy in 2024 establishing the systems and processes that we needed to govern and manage the programme of work effectively. And a key part of that was the impact and feasibility assessment that you can see on the screen there in front of you, which Jim has just alluded to. We developed this in May really to help prioritise some of our key big new priority areas. And as you can see, there's been a considerable movement on some of those things over the course of this year. And we'll touch upon that in subsequent slides so you can see what that progress has looked like. So complex households, I think, was one of the things which was a little bit of an outlier, so we've done quite a lot of work to move that forward, and I'll touch upon that in the strategic commissioning section. But also just to say that with medicines management, is obviously a big priority for the ICB, and we've done considerable work over the last few weeks to help plan and align different programmes of work across data interaction, the business intelligence function, the Civic Health Innovation Lab, and also obviously the data interaction team and medicines management. So as we move into 2024, there'll be a lot more work and progress around that particular priority. So moving on to our Population Health Management Academy, which we deliver in partnership with Innovation North West Coast. We've commenced the programme of work in late May, so we've had just over 6 months worth of progress, and we've reached out to a number of different organisations and teams, and we're delighted to say that we've had over 200 people attend our masterclasses session, which has covered 4 different topics. We've had 40 people work through the accredited programme in the academy, and there is also a really big complementary piece of work that's happening with analysts from across the system. There's over 150 analysts as part of that programme, and all of this is translated into data-led models of care which have reached almost 5,000 patients. So we're very much keen to build upon this progress over the course of the next year. And Ian, I don't know if you perhaps want to make
just a very quick note. The board received an update on pop health and on this part a few months back, so we're looking at what it's really great development as part of the system moving forward. And I think Jim and Rowan will reference the national team very much taking an interest in what we've been doing in a good space there too.
Thank you, Ian. So next year, or this year I should say, we're aiming to reach 20,000 patients with these data-led innovations, and we'll also be hosting a large graduation ceremony for all candidates of the Academy, both the general programme and the analytical programme in the summer.
So, I mentioned at the introduction, a key piece of the work that we do is our engagement with the public, when we came in April, we made a commitment to involve the public in all of the work that we do. We've had a number of events, World Cafe events, patient forums, some online, some face-to-face. We developed a data for research report. I won't go through it clearly, but what I will say is one of the key messages is the public are very supportive of us using data to support population health, to support research, and it has been very encouraging to know that the kind of sentiments that are echoed around this board table are reflected in the way that the public think about how we should use data. So that's been excellent. As we move into 2025, we'll see now the establishment of a public patient advisory group, which is a permanent piece of governance to whom we can go and test future ideas, and there'll be a wider scale public awareness campaign around the use of data that could start in late February and early March. So that's a key element of the work that we do.
I'm frightened of going out too far. So optimising our assets and products is obviously a key part of what the Data Interaction Programme is about, and we are very fortunate with the assets that we've got available to us in Cheshire and Merseyside. So we've done a lot of work in recent months to really launch this and get it off the ground, very much supported by partners from across the patch. It's nice to start off with an example really here in Bootle today of the Sefton integrated care teams, obviously delivered in partnership between general practice and Merseycare and other stakeholders. And the ICTs commenced an initial phase to proactively support elderly frail patients with unmet needs. The aim being to provide holistic care to patients, also accounting for the social and broader determinant issues which are obviously significant and must be considered as well as the medical profile of patients. So the impact of this is to reduce pressures on general practice and also non-elective care, and Soft Intelligence is currently supporting this with a formal evaluation to follow. The next phase of this model is high-intensity users. I'm sure many of us are familiar with this as a concept of people who perhaps have a huge amount of episodic care from a range of different sectors and services across the system, which quite often don't bring a huge amount of value to patient outcomes, but also unsustainable really for the system to continue to support. So mental health is going to be a key part of that new model, and we look forward to seeing the outcomes of that. A very similar piece is the Cheshire East Care communities, again similar in terms of a neighbourhood model designed to meet those broader determinant challenges. Some great progress has been made in Cheshire with circa 450 patients seen in a relatively short period of time, and these teams work across 8 different care communities, and they'll be very much looking to build on this progress as we move into this year. A couple of quick examples in terms of work that's happening around long-term conditions. A really good exemplar has been the telehealth service, which has made great inroads, has used the data to just remove some of those really challenging barriers which prevent services from often seeing the patients that they are commissioned there to support. And in the beginning part of 2024, their caseload was circa 250 patients for the Liverpool population, and then by the end of that year that was almost 2,000. And there's also a great evidence base for telehealth in terms of reducing admissions, so it's absolutely the kind of work that we'd be wanting to promote. A very brief example, which I won't go into the detail of, is the respiratory work there, and we are working hand in glove with our clinical networks across Cheshire and Merseyside. We see that as a great opportunity to proliferate this approach and to ensure that there is that ongoing learning. And I would also say that I think, personally speaking, having worked with clinicians in these kind of discussions, there is a real appetite and I think a real job satisfaction from clinicians working in this kind of way. They're using their skills to target those people who would benefit most from their skill set. I know this board before has seen information on fuel poverty, so I will be very brief in just picking out some of the most salient points here. Obviously it's been a great piece of work and it's well established, Over 650 patients have received targeted care via the fuel poverty approach, and that's translated into over £360,000 worth of investment for those households, which when you think about the difference that can make to people's lives, I think is absolutely the kind of thing that we really should be trying to work upon. And some of the initial findings yet to be published, but initial findings have said that it does seem to be making a difference in terms of A&E attendances and admissions, and very good patient feedback from patients who've gone through this approach, overwhelmingly expressing the positive impact on their mental, physical and financial well-being. So just moving quickly on, you can see that this slide is describing a number of the different proactive models of care that are important to the Data into Action programme. We've made some good progress in the areas that you can see highlighted in green for this year. What we have learned as part of this is that if we want to take a person-centred approach, we must coordinate and align these different proactive models so that we don't create more complexity for patients. People do obviously already have multimorbidities, and we see that trajectory likely to increase significantly. So this coordination and holistic oversight is really important for places working in partnership with the clinical networks and others, and GPs of course. So this is central to the shift from acute to community. So for the Data Interaction programme, this is a big focus for this year, where we expect it to be bigger, broader and more impactful than it has been to date. So our enhanced focus for 2025, obviously for Data Interaction, it's all about utilising system data, and we want to affect change in the system as a consequence of having access to that amazing asset. And a big part of this for us is about the strategic commissioning approach. A key concept around that is the segmentation approach that we take in Data Interaction, which doesn't just look at medical and physical issues, but also looks at the context in which people live. We introduced this as a concept at the Senior Leadership Forum in December, where we explained how just 8% of families are accounting for 34% of health and social care spend. So we've done a lot of work over the course of this year to take us from that sort of academic piece into a much more sort of tangible, practical application. We've now got a complex households dashboard, which we've been rolling out. But what we really want to do is drive a consistent approach through the lens of the complex households. We want to shift to a more family-based dynamic, where we understand the importance of the household context. We know that if a child does grow up in a complex household, their life chances are materially and significantly affected, and it's vital that we get upstream of that. So just as a quick summary, some of the key actions that came from that Strategic Leadership Forum in December. I won't go through those in detail. I think that most of them are fairly self-explanatory, but I think something like a central repository of information where all of our collateral and assets around complex households are shared and understood. We've seen in Sefton, there's been some great work with Dr. Mark Wigglesworth and Southport and Formby PCN for Complex Lives MDT, and a raft of other things across different organisations, where if we can take a consistency of language and approach, I think we've got a real opportunity. I think it's also useful just to mention the connected care record, as Jim has obviously just mentioned. The digital and data architecture that is now that is needed to support strategic commissioning has obviously just been supported by that Finance Investment and Resource Committee. That connected care record is part of that, and it's hugely beneficial to this segment due to the amount of fragmentation and duplication of interventions that happen. So having visibility of that should be a real enabler for us. And then lastly on this piece, the financial and contractual innovation that we need to advocate for and embed is going to be essential if we're to unlock the potential of that over £300 million we spend in these families. And I'm sure they would like to see things also done differently. But we're fortunate in that we have got additional support by the Federated Data Platform Population Health Management Solution, which will develop our capabilities in this area.
So I'll just finish this part of it just by talking about the Federated Data Platform. And I think that perhaps the board is already aware, but it's worth repeating. Cheshire and Mersey ICB are considered an exemplar in the area of population health and in the work that this board is supporting. And therefore, and were selected as the place that NHS England would develop an incubator product for population health management for the Federated Data Platform. The key thing about this is a lot of the work that we do at the moment that we've talked about is about cohorting and identifying patients. This product that is being developed with some of those around the room here is about some additionality which says if you took a strategic approach, what is the additional data that you would require to support strategic commissioning? It largely falls into those areas around health economics, understanding allocative efficiency, getting the financial flows right, and from there, then being able to do some of the work that we already do, the work that we've demonstrated today, then being able to cohort people and then take preventative measures. So it is a virtuous circle that the Federated Data Platform will help us towards, and very much strengthens the position in terms of supporting strategic commissioning. So we'll move on to the last slide, but I'll leave this for you, perhaps, Rowan, just to sum up.
Thank you. In challenging times, pointing our resources to those who need it most is the right thing to be doing. Making the biggest impact to improve the outcome of those we are here to serve, and indeed identifying where we're making poor use of resources because they don't make a big impact. A way of freeing up the money that is needed to move it has to be the right thing to do. It improves the lives of those living in most difficult health inequalities, and is absolutely what we were constructed as a board to go out and deliver. We have this capability, and the ask of the board today is not just to appreciate the commentary that we give, but to help us move to embedding this as the way we do all of our business, and that we start to have the governance within each of our places, across all of our programmes, to inform the financial planning, that we are using this health intelligence in the most meaningful way for those that we serve. Thank you, Chair.
Thank you. Really interesting and remarkably good progress that has been made in that. About 12 months, I think, since I've seen it, especially around the academy, building that capability and capacity. Fantastic. So, any questions or comments? Got Naomi, Steve? Quite a few. I'll come to this side.
I think it's an absolutely fantastic piece of work. I think we've been saying for the last couple of years that we wanted to be able to kind of take a step back and move into more preventative medicine, and this is absolutely heading in the right direction. I really like the fact that the qualitative data has been taken into account as well, and that the patients have been able to feed into this work stream. And I think it just shows that what collaboration across the entire system can do for holistic family care. I did a little bit of extra maths because I couldn't quite work out the figures, my brain wasn't computing it. But with the frailty project, there were 55 patients. It worked out at an average of 26 hospital attendances each, which is one every other week. And it was 155 GP contacts per patient in that year, which, even if we can just half that, if we can have, a 10% improvement on that, that would free up a massive amount of GP appointments and, and time within emergency care. So I think that this is really important for us to work towards. I suppose my only ask is that if this is approved, if we want to roll this out, if we want to see outcomes for next year, we need to move quickly. As I've said before at board, GP data is cumulative throughout the financial year. So the clock starts again in April. So if we want to see those changes embedded within general practice, we need to be getting them in place now so that we can start making those changes from April.
Thanks. Andrew?
Thanks very much. I mean, it's fantastic to hear the attention that's being devoted to this and the cross-sectoral working that is right at the heart of it. I mean, it does seem like a bit of a moment for this region to be taking a national lead on data interaction and the broader interaction with public service innovation and public service reform, which is it's absolutely fundamental. We had a conversation before about how, as a board, we need to shift into that longer, more medium and longer term framework in order to be able to deliver the efficiencies and improvements that we need to see. And this is absolutely the heart of it. In fact, it's difficult to understate the importance of this for the longer term sustainability, not just of the NHS, but of public services more generally. So I assume you already are, but engagement with what we're hoping to become the Office of Public Service Innovation at Liverpool City Region level is a really important opportunity, both to sort of connect to additional resources from national level, but also to take that whole public sector perspective on this, because it's one of these things you pull a thread and it connects to so many other things. So you're probably aware, and I think you are directly involved in some of the work we're doing in North Liverpool on school absences, for example, which very quickly get into questions of mental health support. We're also doing work on housing, which again is one of these test and learn facilities supported by the Cabinet Office, focusing on housing, but again, connections to health are very present, as soon as the investigations begin on that particular issue. So I just encourage you to break the boundaries really of between public sector institutions, and particularly on some of those tricky issues like data sharing and so on, where often the boundaries between different organisations don't match the real experience, the lived experience of the people that we're seeking to support. So be brave, I would say, in setting out where those barriers exist and how they can be broken down. And then my final point is there's nothing worse for any community to feel that they're being experimented on or sort of viewed as if they were in a laboratory. So community engagement and community support is absolutely fundamental to this, particularly as we address difficult issues like data sharing. And your point that you made about the data belongs to the individuals is an absolutely fundamental one, but that does reinforce the need for this to be community-led and community-supported for it to have the success that we know it can have. Thank you.
Thank you. That was an excellent summary of where we need to be, and it is where we are. And myself and Ian sit on the OPSI board. I chair the technical advisory group for OPSI, and we've just set up an information governance group to address the very issue around data sharing across the civic bodies and the public sector.
Thank you. What's the waiting on? I'm going to go around and then back to who is at the end.
First of all, really important and valuable piece of work, so thanks for sharing that. I mean, using data to inform policy and then use it to inform policy decision making is probably something we don't do well done across the whole of the public sector, so then this project's got more than the impact here. Particularly interested in how it informs healthcare allocations going forward. I mean, clearly, you mentioned in your report, a lot of funding that goes into our various organisations in the remit of the ICB is around activity allocations, what you describe as see and treat, and really we should be moving more towards protect and prevent. I've been bang on about this for the last 3 years here, because the allocations we have to support issues around population health and health inequalities, for good reason, are very, very minimal. And if we can get a spring-out step in order to move that forward, I'll be really very, very grateful. The problem we would have, of course, is pressure on activity on the see and treat. If you start to move the money around, the cake is still the same size. Those are problems and other issues arising, particularly at the hospital at the acute end. So I don't quite how we can do that unless we embrace the concept of productivity, which I mentioned earlier in the meeting. So I think it's a really important piece of work. I think it also helps to inform, the public health teams we have. I mean, I don't understand what they call the health grant, how it's allocated and what evidence and basis the public health grant I've had at my council for the last 11 years has been calculated. I don't think it's been calculated using any evidence at all. What I do know is, in real terms, it's fallen by 30%. It's never been updated properly for inflation. So if you help to inform the GSNAs, if you help to inform our public health teams who contribute to the writing of health and wellbeing strategies at the local level, I think this piece of work has got some real value and importance, other than the ones you've described. So thanks.
Thanks. So there's bound to be a shopping list of asks here. But let's not respond to them directly here today, but collect them. Who have we got first then? It's Trish.
Thank you, Chair. Thank you, Jim and Andrea. It's a fantastic presentation and paper. And for me, there's a number of standout messages and highlights in both of them. But just wanted to highlight two key things for me. One is without this, we will not achieve a left shift objective that we are signed up to and committed to. And secondly, the importance of resource allocation of finite resource to the most appropriate need in terms of our patients. Delivering good services is not enough anymore. Delivering good services but also improving outcomes and reducing health inequalities is work that is the responsibility of all of us. And without this, I don't think we will reach that. So fantastic, complete support of what you presented and the next stage is the best.
Thanks, Trish. Ruth?
Thank you. Everything everybody said, it's brilliant, really interesting to see how we can use data in a much more proactive way. I suppose I'm trying to think through how do we embed this in the challenges ahead of us, which is the need for a 3-year minimum strategic plan, and align it with where we are with finances and understanding our finances. So in terms of the recommendation of the paper, it's to mandate that we deliver certain programmes, but I'm trying to align that with, we're going to have a discussion about commissioning intentions by March. So how do we integrate this work in a way that takes us on that strategic journey to get a sustainable health service for the future? So I almost, this is like a separate piece of work at the moment, and it's how do we, what's our path to get to an integrated way of working which aligns the money with this type of working so that we get the right data and outcomes for the patient, the population.
Really great challenge. I think we would be looking to Graham and the exec team to help us figure out an answer to your question, but it's the critical question. And my start would be to look at our look at Mark and our CFO and the need to drive 3-year strategic plan around our financial viability. And it's inconceivable that this wouldn't be integrated into that. I'll come to you in a sec. So that's a go away and think about it response, but just emphasising the importance of it. Adam?
Yeah, well thank you. I attend the Fuel Poverty Steering Group and it's been fantastic seeing the work, and today seeing the bigger breadth of the work has been truly eye-opening. So thank you for that. I think I agree with previous comments about this being crucial to us achieving the aims we need to for the population we serve, and I think these comments around that strategic and financial element being critical resonate as well. I do have a boundary challenge for you, I suppose, and particularly around data segregation, because I think we're very good around using different locations. So we've seen things like searches of GP practices, identifying which cohorts of patients we need to go after. I come from a community pharmacy background, so I'm trying to think, how do we get the data to the pharmacies on who they need to have which conversations with, when patients from a single practice may well attend up to 40 different pharmacies, and at one pharmacy they'll see patients from a myriad of different practices coming in. And that's a real challenge for me. I think we've already mentioned today the problems where things like problematic polypharmacy bring, and how we can use data interaction to target the right people, to have the right interventions with, I think will be critical to solving those problems. And then we have, as an OTB, we have how do we commission the right services in the right place based on what the data is telling us. That gives us a secondary problem to solve. But at the moment, that segregation issue I don't quite think we've got the boundaries of data or the boundaries of getting the right information to the right place quite right as we broaden the programme.
Thanks, Adam. So there's some questions, I think, for John in there as well in terms of that accessibility. But Ian, I think you're next.
My one's just a very quick one. It's great to see all the comments echoed down the room, how important this work is. One of the key things that's important about working in the system, Stephen, the local authority, linking through public health, but public health isn't the only door into our local authority, so I suppose it may be an ask for yourself and Andrew is there to make sure that we're connecting with the right intelligence leads within the local authorities too, because there's some wider profile work I think we could benefit from doing that, if that's all right.
Good suggestion. I think that's what the reason I'm coming back to Greg.
Thank you. It was really good to hear the role that Health Innovation Network have played as a key delivery partner in this. So thanks for mentioning that, particularly around the Population Health Academy work, etc. But I think at the risk of repeating what others have said, it's such a good example of collective working across this system, the organisations, but with local people as well. And it's great to hear that NHS England are recognising this as a leading example of this type of work. So I think there's a fantastic opportunity for us to stand on many a regional and national platform around this and really lead the way. So thank you.
Thanks, Louise. Great.
I'll be exceptionally brief, Chair. I hear what the board are saying to us. We're right to celebrate this. I suppose what I would describe to you is we've gone through a process of capability and infrastructure. We're in that kind of social movement for change space where everybody wants to be using this. We now have to convert that into our business as usual processes, and this is all part of, I think, making the organisation, let's say, 10-year plan ready, or you could say making us ready to be able to attack the 3 shifts that our new government described with such passion and focus. So thank you.
Okay, thank you. And Rowan, in the paper there's a specific ask, isn't it, of the board about creating government arrangements at place. Let's not debate that now. I think you've got the sense, haven't you, that the board is hugely behind this. Working with our place directors, let's understand what that is, and if it needs to come back to the board, great, otherwise just get on and do it.
Thank you, Chair.
Thank you. I know I'm way over time. We've got Laura. With Laura. Thank you. Thanks, Holly. It's a really great presentation. So, welcome Laura and Chris.
So hopefully we won't take up too much time, so I know we're running late, but we wanted to bring an update on this really important area of work. So I'm Laura Marsh, I'm the Place Director for Cheshire West, but I'm also the Cheshire and Merseyside sponsor for the Neurodiversity Recovery Programme. And I'd like to introduce my clinical colleagues. I'm Dr. Chris Reed, I'm consultant child and adolescent psychiatrist.
Sorry. I'm Dr. Chris Wee, I'm a consultant child and adolescent psychiatrist, and I'm the CYP lead in the programme.
Hi, I'm Dr. Chris Pritchard, I'm the GP on the Wirral and the adult ADHD clinical lead in the programme.
Thank you. So in terms of neurodiversity, we have 2 parts to our programme. We're working on children and young people, which for children with additional needs goes up to the age of 25. We're also working on the adult ADHD pathway, because there's been quite a lot of work done on adult autism, but adult ADHD is an area that has really given us considerable cause for concern post-COVID in terms of the numbers coming forward and the lack of support and infrastructure there is in services to respond to that need. So in terms of neurodiversity, we're primarily talking about ADHD and autism. We recognise there are wider neurodevelopmental conditions, but we wanted to start there, which is the area of biggest demand and need, and then we will look to expand over time to make sure that we've got comprehensive support for all neurodevelopmental conditions and a much more integrated response. We know that we're not where we need to be. There is a huge amount of demand for support for particularly children and young people's needs coming through our education settings, that's resulting in large numbers of people sitting on waiting lists, and those waiting lists having to then manage that clinical risk associated with long waiting times. So we put this programme together with the support of not only the health colleagues that you can see here today, but we're working very closely with all 9 local authorities, and the programme is co-sponsored by the Director for Children's Services at Sefton, Risgard O'Hare, but we're also working within those local authorities with multiple professionals across educational psychology, directors for education, family services. It's a very comprehensive and quite complicated programme at times. So as you can see from the slides, I'm not going to go into detail around all of the numbers and the waiting lists today, but we have seen a significant rise in the prevalence for both ADHD and autism in our children and young people over the last 4 years. And this is probably not even where it's going to get to. This is the current prevalence from the diagnosis and assessments that have been able to take place with the capacity that we've got. The actual prevalence is probably yet to be understood for neurodiversity. I think we're closer to understanding it for autism. I think for ADHD, we don't actually know what the prevalence rate is. It varies internationally considerably, with America being much, much higher than many other countries. So as well as the diagnosis and prevalence rates obviously increasing, the referrals coming through are changing significantly in a short period of time, and that's just what this slide is demonstrating, you know, particularly as an example there for Holston, significant increases as people become more aware of how to go through the process and to recognise the potential neurodiversity traits. We are working on what our total waiting list is. So this is an example for Cheshire and Merseyside Partnership, which we have a good and rich data set for, which details exactly how many people are waiting for autism and ADHD at all the different age groups. This is quite unique. We don't have this quality of data for all of our providers at the moment. That's something we're working with them on to get more consistency across Cheshire and Merseyside in terms of what we've been asking providers to detail for us. So it's a work in progress. Overall, from an NHS waiting list perspective, we believe we have over 40,000 people waiting for ADHD and autism, but that excludes those who are already referred into the independent sector, which is a significant number as well, particularly for adults. So we're still in that data quality refining process, but we'll be able to continue to work on this and have the waiting list dashboards for all of our NHS providers. And then obviously as a programme, it's less important around where we are now and more important about understanding where we need to get to. So what is the workforce that we need to make the waiting list shorter, to make the wait shorter, and to improve the access to support. So we're trying to model at the moment the different projected levels of demand for the different age groups as we go forward. That's proving challenging because of some of the data quality issues we've got, but we also want to work nationally and regionally with colleagues on this, including colleagues in academia who can help us with their different research experiences of what the likely prevalence is. And some of the complexity comes from understanding not just the total prevalence, but who are the people within that really need the support of a much more comprehensive kind of support offer. ADHD and you could argue autism, they're not mental health conditions. They're things that people are born with. They are the way that you operate and work, and therefore it's unique as an area to work on. We're sitting it often within mental health provision, because some people have overlapping mental health conditions, or many do, but in and of itself it's not a mental health, they're not mental health conditions. So, to look forward and the opportunity for children and young people, we've described here, hopefully on one page, it's quite difficult to get it on one page, but this is the basis of where we want to get to as a Cheshire and Merseyside neurodiversity pathway for all our children and young people. The emphasis is on those 3 big blocks in the middle, so much more early help for our children and young people through primarily their education settings and in the community, wrapping around the family to meet those needs earlier and in a comprehensive way. To then, for those with more complex needs that can't be met just by that early help, to ensure that that assessment and diagnosis happens in a streamlined, efficient, effective way, so that more people are seen more quickly and in a kind of one-stop shop. So you go one day and have your needs assessed for both ADHD and autism where appropriate. And then the third kind of strand is around that ongoing support. So whether you've got a diagnosis or not, there are ongoing help and support needs for many children and young people throughout their transition of education from the early years, primary school and secondary school, and up into adult services. This is very much a multidisciplinary approach, and it's very much about health and care working together, because we want to ensure that that early help support is provided by schools working with voluntary sector, working with health provision out in the community in a very comprehensive way. So it's really vital that we ensure we've got the engagement of our teams within the local authorities within the education settings. So to make sure that what we were thinking and developing was what needed and wanted by children and people and their families, we commissioned the third sector to undertake a big piece of engagement work across all 9 of our places. They went out and had small focus groups and conversations with over 400 children, young people and their families. They used the Lundy model, and they really tried to ensure that they understood what children and young people want from a neurodiverse pathway. So it gave us a huge amount of learning that's played into all the work that the clinicians and the health professionals, social care, are taking forward. And we're making sure particularly that everything we do now and everything we produce will obviously be co-produced with children, and they've put their hands up to be involved. So that's really, really great. And we've done an easy read version and a video if people want to see that. So before I hand over to Chris, just wanted to summarise what we'll be doing under that early help. So this is really crucial. We will be looking at what we have in each of our places at the moment. It's called the local offer. It's on the local authority website. We've mapped all of what exists at the moment and identified the gaps. And we'll be working with commissioners in health and care to start to address those gaps in that early help offer, to make sure that we've got a more comprehensive, consistent offer across our 9 places. We are also rolling out a profiling tool across our 9 places, starting with Holton and the Wirral, who are undertaking that at the moment. The profiling tool is something that each child will hold. It looks at what their individual personalised needs are across 9 dimensions, and that can then act as their help and their support to access the services that will meet those needs. It can also then act as the referral if they need to go on and have an assessment. So that profiling tool has come from learning in Portsmouth and Cornwall. We're part of a national community of practice, and we're learning and sharing and adapting that tool for Cheshire and Merseyside. So that will be really exciting, and we're evaluating that as well as to the impact of the profiling tool. And the other change that we want to make is in each place there will be a neurodiversity team. It might be a a virtual team, but working together as a single point of contact for families, for the children, and also for schools and education settings. So there's one place to go to help them with undertaking the profiling tools and navigating that pathway and that support. So then we'll move on to the assessment part of Chris.
So this slide describes the assessment part of the neurodiversity pathway for children and young people. So under this overall pathway, assessment itself becomes a smaller part of that overall pathway, which kind of needs joined up approaches across the whole system. So we increasingly recognise from research that a part of the population is neurodivergent and may need reasonable adjustments, special education needs support, may be at more risk of presenting with mental health issues. However, not all of that population has a medical diagnosis, has a neurodevelopmental disorder. And I think one of the multiple causes that leads to increased numbers of children and young people needing to sit in waiting lists and increased demand for neurodevelopmental assessments are the increasing recognition that we are very diverse. We have different needs in terms of our cognitive profiling, our information processing, but often diagnosis is being used as a barrier to access further resources, often forcing families to request diagnosis or to come back with second opinion requests after they have found not to meet the diagnosis. So we're looking at various ways. This assessment model is being co-produced both by stakeholder workshops and families being part of the workstream alongside professionals and representatives from places. We're looking at can we use more effectively the existing resource we have to ensure that children, young people and families can go faster through the assessment pathway, thus also reducing waiting lists. Can we sort of stack, as NHS England call it, can we stack the different assessments that a child and a family need to go through? We know that the same questions are needed for both an ADHD assessment and an autism assessment. So we're talking about combining those assessments so children can actually sit on less waiting lists and be assessed more efficiently, therefore improving the quality of the experience and improving throughput, but also improving the quality of the assessments as well for clinicians. We're talking about improving the communications during the assessment part of the pathway, and we have a co-produced communication toolkit co-produced with families to produce the letters, because that's a major theme about poor communication, causing more anxiety while people are waiting for assessments. We have created a stratification tool so that actually, rather than offering assessments in referral order, we should be offering assessments earlier to those children where actually not having the assessment or not having a diagnosis is going to worsen their health outcomes. So we have a stratification complexity list of factors that clinicians within this region have designed and also has gone through co-production with families to sort of help standardise the approach to prioritising assessments as well. And we're also currently working on the skills mix documents as well, so that we can advise more sort of standardisation across the region. I think we go to the next slide. So we're now talking about sort of ongoing support across the pathway rather than pre-diagnostic support or post-diagnostic support. Because actually we recognise that children and young people are going into the pathway and coming out the other end with the same special educational needs or mental health needs as whether they get a diagnosis or not. So actually, ongoing support moves towards early sort of help, preventing the development of mental health issues, preventing children and young people failing in education. So we're talking about ongoing signposting to the joined up offer from health and local authority and the voluntary sector in every place. That offer should depend on the child's needs, not on having a diagnosis. We're talking about a smoother interface with the mental health pathways and the intellectual disability pathways. So we're not having to wait for diagnosis before a child sort of gets onto those pathways, but we're actually talking about earlier, preventing earlier intervention to prevent later crises.
The medicines optimisation team is also looking at the transparent costings for ADHD shared care with primary care and GPs, and that, when it comes, will be considered for consideration forward planning, so that we've got much more transparent, upfront, explicit costings and what is expected. So I think that's the main headlines from that.
So I'm just going to talk through the adult ADHD model, which you see in front of you, which is the basis of our work across Cheshire and Merseyside. So this has been co-produced with adults with ADHD and also significant help and support from our colleagues from the Health Innovation North West Coast Network. So predominantly this involves a significant change in how we sort of access and also diagnose patients with ADHD. So rather than it being a secondary or a specialist care-led service, it's moved into the primary care enhanced service going forward. It has specifically 5 changes in terms of this model. So change 1 looks at a consistent sort of education platform. So individuals who present with any symptoms or concerns around a diagnosis of ADHD, they're feeling where to go, and you can access that in terms of any issues around their sleep, employment, social issues at home, and it's an online sort of education that they can easily access at any time throughout the day, and it's available for all ages, which will link into the CYP work as well. The second change is the development of a new, what we call there as a mental health practitioner role, but it will ultimately function as a neurodevelopmental role. So this will be an individual who sits within a local place or a PCN, who is the first point of contact for when someone comes to see their GP or within a community setting and they feel they may have a diagnosis of ADHD or they want some help with some of the symptoms. So it's offering that early help and intervention straight away. So that mental health and neurodiverse practitioner role is there to direct that individual in terms of any issue around their sleep, employment, family issues, and address those needs which you might need rather than just going on to straight for a formal diagnosis and assessment. That neurodiversity mental health practitioner will obviously stay with that person for a number of weeks, and they will use a sort of a risk stratification tool in terms of low, medium and high, in terms of the needs of that individual, so it's personal and holistic to them. At the end of that sort of 12-week programme, there'll be an offer of a patient to go on, or an individual to go onto a self-management platform, so they can, where possible, use our digital infrastructure to help with those ongoing education and mental health and social needs. We also recognise that may digitally exclude some people, so that neurodiversity practitioner is still there and it will function as a hybrid role to help those individuals who will struggle with digital issues going forward. There will still be a need for obviously to transfer any data from primary to secondary care, because we need ongoing help from our colleagues in secondary care. There's a certain group of patients who are not able to be managed successfully within a primary care setting and need that specialist support, but we recognise that will be quite low, hopefully, in terms of the number going forward, if we address issues at an early stage and don't let them to spiral into a sort of crisis situation for lots of people that we're finding lately. And another significant change is that we move the annual reviews into primary care. There's always been a stumbling block in that patients would end up being stuck in secondary care, because the guidelines will say that an individual who's being diagnosed with ADHD and commenced on medication would need a review with a clinician who has a specialist interest in ADHD. Now that doesn't have to be a consultant, but it can be someone who's upskilled, such as GPs in certain parts of Cheshire and Merseyside where there's a functional service that we can see those people in a primary care setting. And not only do they do those annual reviews, but that now moves into actually undertaking that diagnosis of those individuals that we would class as being low risk. So most people we would hope would stay within a primary care setting and don't touch a secondary care base unless it's needed, but there'll still be that additional support from secondary care if needed going forward for a small cohort of people.
So just to summarise, we haven't come with the formal ask at this point, but we will be playing these asks into our planning round for next year, because there are a number of these will require investment to enable us to deliver the model that we've just described to you. So I guess the key one for us is looking to invest in the shared care for ADHD medications for both children and adults, so that we can move that activity out of secondary care into a supported primary care model that's paid for, and then that will release capacity in secondary to look after those more complex children and adults. So that's a key priority. But then implementing the model would reduce the waiting times, and one of our ambitions is for children and young people to wait no more than a year for their assessment, which we believe, you know, it's a challenge, but is something that we really need to aim to in the next 12 months, so that children aren't missing out on vital attendance at school, achieving the maximum potential from their education and being part of that community. So really, really important that we try and move towards that. And as part of this, we're also looking at how we use the independent sector and making best value for money from the spend that we've got. So perhaps thinking about shaping what we ask the independent sector to do to complement investing in the NHS, as opposed to at the moment a bit more of an ad hoc use of the independent sector that's becoming unmanageable at times and inconsistent in what they offer. And then really thinking about how we train and support our professionals to understand neurodiversity, to make appropriate adaptations, but also then to be able to signpost people effectively through this pathway that we've developed. So I think I'll leave it there. Thank you.
Chris and Laura, thank you for that presentation. There's so much content in that presentation, and it also illustrates to the board and for somebody like me who's been involved in the children's one over the last 2 years, how much progress has been made in the development of those proposals and the new proposed models of working into the future. And we're reaching a crunch point, aren't we, about understanding how we get this commissioned and finding the funding to enable some key elements of it to go forward. It's really important, and we know what the level of demand is out there in this. So we don't know what the level of demand is. We know that there's huge pressure around these issues that you highlighted today. I'm going to look to our board to make any comments or questions. Ruth?
Just to welcome the comprehensive work that you've been doing. I suppose I have a governance question which links to where are we now in the decision-making process, because the amount of change that's proposed is quite a significant policy change, and there are significant financial implications. Plus, I'd also like to understand better the patient and population outcomes that we're going to track as a result of making all these changes. So I guess it's a governance question now, because the paper's presented for assurance, and I don't know between now and making choices in the commissioning intentions where the board makes a policy decision to go down this route, and I wasn't quite sure on that.
Graham, do you want to give us a view?
We've been clear that this is a top priority to resolve. One of the things we actually have to understand is the extent of resources that's available to us. And we're in the process of doing that. As you've heard earlier, we've only got our allocations, well, I haven't seen them yet. We think they were published today. And the question is about how quickly we go, not whether we go. So we named this as a priority for transformation last year. The team have worked on this as a bottom-up approach. So we're going to do it. The question is the money and how quickly.
So therefore today is a policy question for us. Do we accept the policy decision that this is a model that we want to pursue, is what I'm hearing. So I just say this is not for assurance then, this is accepting that there will be, you know, a different model of care. So it just has quite significant implications, and I wasn't sure that we were asking the question.
Yeah, so Ruth has highlighted a really important question for the board. We've heard a presentation today which is, you know, really accurate and succinct, but we don't have the usual stuff behind it that enables us to sign off. You know, a policy or model change. So we would normally look to a forum in which to do that on behalf of the board. Is that quality and performance? I'm looking at Williams. Claire, from a commissioning perspective, where does that go to enable this board to have the issues and the risks identified that we should be considering before signing up a model of care?
we've got the SEG, and I can't remember exactly what clinical...
So clinical effectiveness
The
group
effectiveness
would be where we kick the tires on the clinical model. Then it would absolutely need the detail of resources sitting behind it to deliver that. And there's something about especially a shift to primary care that we've got the buy-in in the face of collective action, of shared care, which we know can be a challenge. I feel that there's quite a bit to work through.
Okay, so let's make sure we're clearly setting out that pathway, so our colleagues know which way we need this to go to before it comes back for approval at this board, if the approval is needed from this board. Andrew?
Thanks. Really welcome the focus the discussion is demonstrating on what's a really important challenging issue for not just the NHS but for wider public service community. And I guess that's my key ask really, is that the engagement with the schools community is really strong in this, and also that sort of profession of educational psychologists employed within our local authorities who are dealing with the consequences of the very significant rise in prevalence or revealed prevalence and the consequences for the education and health plans for young people across the whole region.
Thanks, Andrew. Okay, so thank you very much for your presentation. I think we'll get some further clarification on those next steps from our exec colleagues so that it's really clear what we need to follow through that route. And we look forward to understanding progress in due course. Thank you for that. Quickly before I need to finish the meeting, any comments before I seek approval for minutes of the last meeting? So can I seek your approval for those minutes? Yes, thank you. You can see the board action log. Good to see the progress. It's being cleaned up. I haven't got any specific questions on it. People happy to accept that action log? Any updates? Thank you. So, where we are, we're half an hour late. I can see some of our colleagues who are due to present at 2 o'clock. We need a break. Are you okay if we have 20 minutes or so? Or half an hour?
We have to resume our private board at entry at 3:30 with the CQC present.
All right.
So we'll need to leave here at 3:10 to be just about.
Okay, let's grab a bite to eat. Let's try and get back in 20 minutes and we'll kick off.